Hello. Yeah. हाँ नमस्कार सर. आपका मैंने डाल दिया, वोट डाल दिया आपका. हाँ मैं एक मीटिंग में हूँ. हाँ सॉरी. हाँ
Hello, sir. I'm audible, sir?
Yes, sir.
Thank you. Thank you.
Mr. Amit, the Harsh has not joined, I think so.
Harsh is not joining. Acha, wo
Okay.
ये वाला AV वाला Harsh you were telling?
Yeah.
I
Good
don't
Harsh,
know.
yeah.
Dr. Amarnath.
Administration. Administration wale Harsh.
Okay.
Because he has to put the slides and all those things.
He has messaged me that both names. Maybe update.
Amit is there in the attendees, but okay, he.
अरे ज्वाइन कर लेना भाई, सर बोल रहे हैं.
Okay, he's there. Don't.
ओके भाई.
Open. Shall we open, Dr. Dinesh?
Dr. Vijay has joined.
He's
first-
I just called him up. He's
Let Dr. Vijay join, and then only we can start the sessions.
Ehsan is also in.
Dr. Tomar is also not joined. Okay, he's there. He's there in the attendees. Dr. Vijay, you had a talk with Dr. Vijay? Any issues with him?
Calling him again. He said have you been able to join him, sir? He has joined with the workshop ID again. I've just told him. He was not able to.
I think there's some confusion, and then we'll be starting the session.
Thanks.
Dear delegate, just bear it for 1 more minute because our first speaker is yet to join and he's joining. So we'll be starting session in just 1 or 2 minutes.
There must be Dr. Ehsan in the delegate. I think he has joined as a delegate. We can do the second session first and then the first session.
Okay, what is spelling? Can you?
IHSAN.
IH?
SAN.
Dr. Ehsan is there, okay. Okay, Dr. Shalini, then let us start.
And we
And
can
the
start with the session of Dr. Ehsan. If
Okay.
welcome, Dr. Ehsan. Good afternoon.
Good afternoon. Hello.
Actually, I think you didn't join with the email link. That's why you have reached the delegate group. It's fine.
No issues, no issues. That's absolutely fine.
Shall we start now, Dr. Dinesh?
Yeah, let us start.
Yeah, a very good afternoon, everyone. Thank you to each and every one of you for being here with us again. And we are really pleased to be able to welcome to those that have been with us for a long time, as well as to those who are new to the endocon today. Today is the last date of our endocon, and we are really proud to be able to host it. And I would like to thank to each and everyone, especially Dr. Dinesh, Dr. Richa, Dr. Naginder, and all our North Delhi IAP core members who helped us to make this event successful. And today, as we all know, we are going to have a very interesting quiz session in the end of this, Endocon, and we are having lots of very dignified faculties with us today. And now, without taking much of time, I would like to invite Dr. Dinesh.
Thank you, Dr. Shalini. I think we are already late for a few minutes, and Dr. Vijay has also already joined. I think I should hand over to Dr. Richa to invite the chairpersons, and the chairpersons will be inviting our next speaker, Dr. Vijay.
Okay, thank you. Can you hear me, Doctor?
Yeah.
Thank you, Dr. Dinesh, Dr. Shalini. I welcome you all on the fourth and the final day of our endocon. Thank you for being our patient. Our topic are mixed bag of choices from thyroid to bone disorders in children, followed by obesity. And in the last, we will have a quiz. So we start with the first session, which is on thyroid disorders. I thank Dr. Vijay Jaiswal from Meerut Medical College and Dr. Ehsan from Turkey, who have kindly accepted the invitation to discuss this interesting topic. I invite our chairpersons for these. Our first chairperson is Dr. Cecil Khaka. He is a senior specialist, senior consultant at ESI Hospital, Okhla. He is looking after the pediatric endocrinology department in the institute. Our second chairperson is Dr. M.S. Tomar. He is a senior consultant at Sarod Super Speciality Hospital. Now I request Dr. Khaka to introduce Dr. Vijay Jaiswal. Over to Dr. Vijay.
Okay, thank you, Dr. Richa. It's my pleasure to introduce Dr. Vijay Jaiswal. He's the professor and head at Department of Advanced Pediatrics and Neonatology at Meerut Medical College. He is also the founder of SWEET, which is a help group for children living with diabetes. He started the Universal Congenital Hypothyroid Screening at Meerut Medical College. And he's also associated with a number of societies, the Grow Society of India, ISPE, UP, He was the secretary of IAP Meerut from 2017 to 2019. He has over 15 international and national research publications. So I welcome Dr. Vijay Jaiswal, and he can give the presentation. The topic for presentation is universal newborn screening for congenital hypothyroidism. Dr. Vijay Jaiswal, please.
Thank you, sir. Thank you for your kind introduction and words. So without any delay, I'm going to start. So yes, it is visible and audible.
No, sir, your screen is not
Audible
clear.
but not visible.
Kindly share the screen, sir.
Yes, just I'm going to do that again. So this is share screen.
So you first open your presentation and
Yes,
then.
yes, that I have done. Yeah, I think. Oh,
Absolutely fine. So make it full screen.
hold on. Yeah, I think it's now open.
Yeah,
Yes,
yeah,
sir. Yes.
yeah.
Yes. Okay. So, good afternoon, you all. And after lunch, maybe you feel sleepy, but I'm very sure that I'm not allowed to do that. So it's really an eye opener to all of us that if you, before I'm going to discuss the things, just I want an interaction from all the audience that how you are going to describe this picture. Yes, I am going to wait for another 10 seconds. So please have a look on this picture and please describe it. Yes. So any of you, please, for 10 seconds, I am waiting.
Dr. Anuradha has written in the chat box, it's a dull-looking child.
Okay, dull looking child. Any more addition?
Macroglossia, dull expression,
That's good.
slumpy, dull
Yes.
child.
Yes. So my job is over. That whether you really want to see all the classical sign and symptoms in a baby who has been delivered, and you are going to diagnose on the basis of this clinical equipment, and then you are going to order TSH, or you want to do something else. So of course the answer will be in unison that we don't want to see any kind of this picture. It will be better if this is only in the book. But sad part is that still we are going to see so many pictures, so many babies, and even beyond that. So I'm going to share one case scenario, and after that I'm going to start my talk. So you can see here that this is a 12-year-old boy. Yes, I'm not wrong. This is a 12-year-old boy brought to endocrine OPD with complaint of global developmental delay, short stature and low IQ by anxious parents. He was shown to several practitioners for years, even to the many pediatricians before coming to endo department. So what is your diagnosis and how can you help him now? Yes, again a 10-second pause. Yes, so what is your diagnosis?
Hypothyroidism is the first answer.
Okay, thank you.
Hypothyroidism.
Thank
That's
you. Yes, so he is a victim of congenital hypothyroidism. And but the sad part is that it's too late. It's too late. So though we can diagnose, but how we are going to help this child or this family, whether he will be able to participate full-heartedly in a productive society, of course, no. So in my coming talk, what are the learning objective that what is the importance of newborn screening for congenital hypothyroidism? What are the practical aspects of the screening? Which sample to be sent? Timing of the sample? What tests to be performed? If the tests are there, how we are going to interpret the screening test, and whether that on the basis of that screening test, whether some more tests are required. If you have diagnosed, how to evaluate that baby, how to manage that child, and what are the various things you have to see in the follow-up of that particular child who is living with congenital hypothyroidism. So congenital hypothyroidism, commonest cause of preventable intellectual disability. But the sad part is that still we don't have any national guideline or national policy to have congenital hypothyroid screening in India. About less than 5% babies are symptomatic at birth. So 95% babies are going to have asymptomatic, and they will be presenting late with complications. We don't want that. 10% shows symptoms in the first month of life. Near normal, and why I'm caveating this thing, that near normal life outcome, if it is diagnosed and treated before 2 weeks of age, that within 2 weeks of delivery, delay in treatment causes permanent neurological damage, you have seen. So there is inverse relationship between the age and the clinical diagnosis of congenital hypothyroidism and the outcome. So you can see here that as you are going to delay in the diagnosis, the child is going to lose his mean IQ. So again, so that's why it has been said that this is one of the most cost-effective screening program, and this is the commonest cause of preventable mental retardation. So this is the rationale for newborn screening of congenital hypothyroidism. That is common disorder, more common in India than developed countries. But of course, we don't have exact data. The data we are going to have are from institution which are going to have some sort of this screening program. And incidence is 1 in 1,000 to 1,500. Even in some studies of Kerala and South India, they have reported 1 in 750 also. Screening method, that is TSH dependent, cheap and easily available, highly effective and relatively inexpensive treatment once you have diagnosed this congenital hypothyroidism. And this is one of the most cost-effective screening program globally. Now, again, this is a puzzle for you. And yes, I'll give 10 seconds for this thing. That can anybody tell me? They can unmute themselves and they can tell the differences and what can be the probable diagnosis in these both pictures. They are looking the same or something different. So please opine yourself by unmuting yourself.
Dr. Jaiswal, they will be able to write in the chat box. They cannot.
Okay, that's fine. That's fine. So just a quick comment that
Down syndrome, puffy eyes are the few. I will just read the chat out.
okay, and in the second picture,
first one, before and after. I will just read. Sad child and dull child, before and after CH treatment.
Okay. So thank you. So sole credit goes to pediatrician. No. Here, that's why I have put this picture that in the first baby, TSH and thyroid screening was done on the basis of the clinical symptoms. And this baby was diagnosed by congenital hypothyroid screening on the universal basis, that all the babies which are being delivered on that institution are going to have congenital hypothyroid screening program. So that's why it is important that if you are going for the thyroid function test on the basis of clinical symptoms and sign, you are too late. So the rule is that the purpose of sharing this picture is that absolutely normal asymptomatic baby at time of birth can have abnormal thyroid function. So that's why it is imperative, it is rather mandatory to have thyroid function test universally. So this is the thyroid physiology in fetus. Thyroid hormone important at all stages of neurological development, that is neurogenesis, migration, hippocampal growth, glial proliferation, synapse formation, axonal elongation, dendritic branching. In the first trimester, maternal thyroid hormone only source for fetus. And maternal thyroxine partially, this is not going to prevent all the things, but partially protects hypothyroid infant in utero. What thyroid hormone does and why it is so much important, why we are going to give crux and this much of strength is that it is like a spice in the life. What it means? So in nutshell, what I can say, that it acts in the metamorphosis or transformation of the body, or say maturation. So at tadpole, if it is deficient of thyroid hormone, it is not going to be converted in the frog, even if his weight is increasing day by day. So that's type of important of this thyroxine hormone. So metamorphosis or the final maturation is not going to occur without thyroid hormone. So what is the neonatal physiology? That is marked rise in the TSS within after birth, peak at 24 hours, normalization over 2 to 5 days. Why this time frame should be understand that at what timing you have done TSS screening program. So cord blood is not affected by TSS, sir. postnatal samples collected before 48 hours can have highly false positive rates. Thought to be due to stress during labor and exposure to cold ambient hypothermia of extrauterine environment. And it is to be followed by rise in T4. So this is the graph how, and you can see here that premature and term baby are going to have different scenario in terms of TSH rise as well as T4. What are the practical aspects of sampling? Because this is really important. On this basis, you are going to bank upon the diagnosis of congenital hypothyroidism. So cord sample or say serum sample. Cord sample easy to draw, no extra pricks required, suitable during early discharge of the mothers. Sample can be processed at any local laboratory. Training required is minimal. Other disorder, so this is a drawback that other disorders can't be screened. Staff on all the shifts need to be trained because at any point of time delivery may happen. Postnatal heel prick, that is filter paper, can be used to screen multiple disorders. Only morning staff need to be trained, can be even done, sorry. Yes, can be even done for home deliveries, needs special assay and reliable central lab, adequate training to ensure error-free blood spot. Postnatal peripheral blood sample is acceptable if filter paper is not feasible because this is not widely available at all places. What is the timing that either cord blood or postnatal sample at 42 to 72 hours, not later than 5 days, should be collected for screening? In case of early discharge of infant from nursery or need of blood transfusion, sample can be collected between 24 to 48 hours, but cutoff value is going to be different. That is on the higher age. Timing of first screening in preterm and SGA, same as in term babies. For sick newborn in NICU, sample should be collected before day 7 of life or discharge from NICU, whichever is earlier. No infant should be sent home without congenital hypothyroid screening. How to collect? That is cord sample collected from placental side of the cord, wipe maternal blood from the cord, collect about 3 to 5 ml by cutting cord between the clamp and placenta or by pricking placental vein with sterile needle and syringe. Store at 4 degrees centigrade temperature for after appropriate labeling and transport to lab within a day. So this is how that heel prick is going to happen. And one more thing that caution to be there, because this elute method, unless and until the blood is enough to fill this whole circle, and you don't have to squeeze, and layering should be avoided. This spotting should also be avoided. So a good pricking is required and a reasonable amount of blood to be there to complete the circle. Yes, the $1 million questions, it's always asked TSH or T4. So primary TSH based screening, more sensitive and specific for the diagnosis of primary congenital hypothyroidism. And basically we are focusing upon primary primary hypothyroidism, but it may miss central hypothyroidism or delayed rise of TSH. In some countries of United States, primary T4 based screening with backup of TSS can identify both primary and central hypothyroidism. Even it will miss some subclinical cases of hypothyroidism. Higher false positivity will be there. But primary TSH based screening adopted by most centers worldwide and is recommended for India also. There are some situations where second sample of screening should be required, and initial screen may miss congenital hypothyroidism. Hence, a second sample between 2 to 4 weeks is suggested. Indication being preterm babies, IUGR, sick neonates, twin pregnancy or multiple pregnancy, Down syndrome, and first sample taken after transfusion. Now, how to interpret the result? That interpretation of screening and confirmatory sample, whole blood versus, so this is a little bit changed, and I have taken mostly from ISPA guideline. TSS from filter paper can be reported either in whole blood unit or serum unit. It is recommended to use serum unit to make uniformity of the reporting. And how we are going to convert it, that we have to multiply it by 2.2. So whatever reading I am going to discuss in the coming slides, all are being in serum units, irrespective of the methodology which has been used for assay. So interpretation of the screening of the results. Here this algorithm, heel prick or by cord blood sampling, TSS, if TSS is equal to or more than 20 or equal to or more than 34 between 24 to 48 hours, but it is better to avoid this type of things. And we have to sample after 48 hours. So 48 to day 5, up to day 5. TSS if it is beyond 40. Physical examination and confirmatory venous sample for T4 and TSS. Start immediate treatment pending results if screening TSS is beyond 80. Now you have done TSS and it is in range of 20 to 40. Repeat screening in second week of life. And if you can see that repeat screening is not feasible, then we have to start the treatment. Or in the repeat screening, if TSS is above 20 in less than 2 weeks of age, or TSS is about 10 for beyond 2 weeks of age, we have to start treatment. So how we are going to interpret the result in confirmatory sample, that we have to see the two parameters, one is TSS and the second is T4. And what is the crux, that we have to initiate treatment as soon as possible and must be before 2 weeks of life. So what can be the condition? If TSS is high and T4 is low, so obviously it is hypothyroidism and treatment has to be started. If T4 is low but TSS is normal, that can be hypothyroxemia of the prematurity, where second sampling is required, sick euthyroid syndrome, or there can be some cases of delayed rise of TSS or central hypothyroidism. Now the second scenario can be that T4 is normal and TSS is borderline high, TSS with normal T4, or so here we have to see, and in case of that TSS is normal and T4 is normal, then nothing, you don't have to do anything. Now the repeat TSS if more than 20 in first 2 weeks or more than 10 beyond 2 weeks, it is high and should be treated. Total T4 less than 10 microgram per dl and FT4 less than 1.1 nanogram per dl is said to be low. Now coming to the another scenario, that is borderline function, that is borderline high TSS with normal T4. What can be the DDs? That is transient or permanent primary congenital hypothyroidism, delays maturation of HP axis, thyroid hormone resistance, which is not a very common entity, Down syndrome and pseudohypoparathyroidism. We have to repeat the sample after 2 weeks and we have to treat if TSS is beyond 10 by 3 weeks of life, even with normal T4. The second scenario with borderline thyroid function, that is low T4 with normal TSS, can be hypothyroxemia of prematurity, sick euthyroid syndrome, TBG deficiency, that is low thyroxine binding globulin level. Treat if consistent with central hypothyroidism. Rule out, but before commencing thyroid replacement, we have to rule out other hormonal deficiency. In other cases, repeat T4, TSS after 2 to 4 weeks and treat if persistently low T4 or you have perceived delayed rise of TSH. Yes, so apart from hormonal assay, what are the imaging utilities, whether we should go for not? So evaluation for primary congenital hypothyroidism, history and physical examination, it is the rule. We have to take the history of consanguinity, perinatal history, maternal autoimmune thyroid disorder, iodine exposure, dysmorphism, associated anomalies, particularly midline defect, or say congenital hypothyroid disease. Imaging to identify the etiology of congenital hypothyroidism. Hearing screening, usually we forget that. Radiograph of knee showing absent of lower femoral epiphysis suggests severe congenital hypothyroidism, and it correlates with later intelligence and motor scores. What it means that even in this baby, you have diagnosed and commenced the treatment within 2 weeks of life, then also this baby may not have all the domains in age appropriate. So they can have some deficiency or delay in milestones. Now coming to the etiological diagnosis, on the basis of that, permanent variety, transient and other less common varieties can be. So the commonest, that is thyroid agenesis or dysgenesis. There can be ectopic thyroid dysharmonogenesis, that is there can be some problem in the hormone synthesis. Transient, that is maternal thyroid antibodies, iodine deficiency, maternal anti-thyroid medication, iodine exposure can have transient effect on the thyroid function test. Other less common, as we have discussed, that is central hypothyroidism, and even more uncommon is resistance to thyroid hormone. So why thyroid imaging to be done, what you want to see, and when to be done. So identification of etiology of congenital hypothyroidism helps in counseling of the family, can avoid interrupting therapy at 3 years of age if permanent etiology is confirmed. And what you have to see that it should always be confirmed by thyroid ultrasound, thyroid nuclear imaging. If no resource constraint, then do both scan as well as USG. I'll discuss that why it should be done. And when that is USG can be done anytime before or after treatment. Scan should be done before starting treatment or within 7 days of treatment. But a word of caution is that we should not delay, or we should not be wait for a long time to go for thyroid imaging. Rather, it will be prudent if thyroid function is so much deranged, then it is better to start treatment. And what treatment should not be delayed? So we have discussed that it should not be delayed. So what is the approach, that what in imaging what we are going to see, that you have done thyroid scan and uptake at the base of the tongue and not in the thyroid area. So it may be lingual or ectopic thyroid. Now in the thyroid scan, no uptake in the neck or elsewhere in the body. Now you have to confirm whether the thyroid tissue are there or not. So USG thyroid you have done, and if gland is seen, it means that the uptake was not there because of effect of maternal thyroid antibodies or iodine uptake defects.
Dr. Vijay, we are already overshooting the time, so I request you to kindly wind
Okay,
up.
just
Please.
I'm going to give the crux and the concluding side in coming. Yes, so just I'm going to explain, and after that, just I'm going to take that. Yes, thank you. Thank you for reminding me. Thank you. So gland not visualized, it is thyroid agenesis. In case of increased uptake, USG showing enlarged thyroid, this can be dysharmonogenesis, and perchlorate discharge test can be done. If normal uptake is there, gland is normal in the position, transient hypothyroidism or dysharmonogenesis can be there. So this is the picture how you are going to look in the thyroid scan. Treatment for congenital hypothyroidism, that high dose of levothyroxine is going to be given by 10 to 15 microgram per kg. And it should be given with breast milk in the crushing of tablet, because we don't have any preparation of syrup. Early and adequate treatment is the key to prevent neurological damage, and we have to check it frequently. And just I'm going to skip some slides. Yes, in follow-up, we have to see that maintain T4 in the upper half of normal range and TSH in the lower half of normal range. And we have to see the growth parameters also. Just I'm going to skip the things. Yes. So these are the concluding side that every newborn must be screened for congenital hypothyroidism. Screening can be done with cord blood or postnatal hair prick after 48 to 72 hours, but not beyond 5 days. A thyroid imaging is desirable in primary congenital hypothyroidism, but should not be lead to delay in treatment. In suspected transient congenital hypothyroidism, re-evaluation for permanency can be attempted at 3 years of age. So this is my concluding side that of course this type of picture we won't want to see in real world. So thank you so much. And yes, questions are always guaranteed in life, but answers are not. Thank you so much.
Okay, thank
And
you,
I'm
Dr.
sorry to
Vijay
take
Jaiswal.
extra time. Sorry.
Thank you,
Thank
Dr.
you, Dr.
Vijay.
Vijay. Thank
There
you.
may be some questions in the question and answers, and I
Yeah.
request Dr. Vijay to answer it, to type the answers there only for the sake of time. Over to Dr. Richa.
Yeah, thank you, Dr. Vijay. The message is loud and clear that all newborns should be screened, and the hypothyroid is a preventable cause of congenital hypothyroid is a preventable cause of mental retardation. So now I request Dr. Tomar to invite our next speaker for the session. Over to Dr. Tomar.
Thank you, Dr. Risha. Am I audible?
Question answer.
Okay. First of all, I would like to thank our President, Secretary, and Organizing Committee, Dr. Risha, Dr. Rupesh, and Dr. Nagendra. And the screen is not there. So we are lucky to have our next speaker from Turkey, Dr. Ehsan Esen. He is Associate Professor in Pediatric Endocrinology. He is Head of the Division of Pediatric Endocrinology, Medical School of Firat, University of Beijing, Turkey. And he has worked as a consultant pediatrics endocrinologist at the Medical School of Firat University since May 2013. His clinical practice includes the full spectrum of pediatric endocrinology and diabetes. He has around 30 international publications. So welcome, Dr. Isha.
Thank you, Dr. Tamer. Share. I guess my presentation is visible.
Yes, it is visible.
Yeah, I am starting. I am very happy to be a participant of this meeting, and I would like to thank the organizing committee for their invitation. Today I will talk about acquired hypothyroidism in childhood and adolescence. The importance of subject is normal thyroid function is critical for early neurocognitive development, as well as for growth and development through childhood and adolescence. The objective of this presentation is to provide a practical review of the presentation, evaluation, and treatment of the acquired hypothyroidism in children, commonly encountered in primary care practice. Please remember the hypothalamo-pituitary thyroid gland axis. Hypothalamus stimulates pituitary by thyrotropin releasing hormone, and then pituitary stimulates thyroid gland by TSH, thyrotropin, and thyroid synthase and secrete thyroxine. Hypothyroidism is defined as low level or absence of the thyroid hormones. Defects in thyroid gland itself cause primary hypothyroidism. Defects at the level of the pituitary gland or hypothalamus cause secondary or central hypothyroidism. The most common symptoms of the hypothyroidisms are fatigue, cold intolerance, menstrual irregularities in adolescent girls, abnormal pubertal development, pubertal delay usually, and sometimes precocious puberty in girls. It's also known as one-week Rumba syndrome. Short stature, weight gain also rarely can be a symptom of the acquired hypothyroidism. There is a key point. Contrary to common belief, hypothyroidism is rarely the etiology of weight gain or the obesity, because much of them is caused by the primary obesity, lifestyle problems. more food, less exercise. In fact, excess weight gain is associated with mild elevations in TSH, like 5 to 10, and with normalization of TSH level after achieving weight loss. Examination findings are the most common is goiter, poor linear growth and or growth failure, increased weight for height index, bradycardia, delayed reflexes, mixed edema of the face and extremities. The meaning of the goiter is enlarged thyroid, thyromegalia. It is non-specific finding of the acquired thyroid disease. According to World Health Organization, no visible or palpable goiter is classified as grade 0. A palpable goiter but not visible in chin neutral position is classified as grade 1. Visible and palpable goiter in chin neutral position is classified as grade 2. Examination of thyroid gland should perform like this. Visual inspection of the thyroid gland and neck in 3 position, chin neutral position, looking up, and midway position with swallowing. After that, we should perform palpation, and during assessment to hypothyroidism, we can auscultate the thyroid gland, but hypothyroidism is not subject of this presentation. Examination of the cervical lymph node is a part of the examination of thyroid gland. Goiter is not equal to the hypothyroidism. If a child have goiter, you should check thyroid functions by measuring TSH and free T4. Interpretation of thyroid function tests in primary thyroid gland problems can be like these 5 scenario. First, it can be euthyroidism with normal free T4 and normal TSH. If free T4 level is low and TSH is high, this indicates hypothyroidism. If TSH low, free T4 high, this is hyperthyroidism. And 2 other scenario is normal free T4, high TSH, this is subclinical hypothyroidism, and normal free T4, low TSH, this is subclinical hyperthyroidism. If the results of the free T4 and TSH, such as low free T4, normal or low TSH, this will be indicated as CNS problems. The probably diagnoses are central hypothyroidism and euthyroid 6 syndrome. Both of these disorders will be presented with low free T4 and normal or low TSH. To distinguish these 2 disorders, we can use the free T3 levels. Free T3 to free T4 ratio less than 2 suggested low T3 syndrome rather than central hypothyroidism from the age of 2 to 18 years. Non-thyroidal conditions can lead to euthyroid 6 syndromes included neonatal period, stress, cold exposure, infection, calorie deprivation, surgery, some drugs, hepatics, and renal dysfunction. The key point is if thyroid function tests are obtained in a patient with acute or chronic illness, they should be repeated after recovery from illness before making a definitive diagnosis. In addition to characteristic findings of thyroid function tests, children with acquired hypothyroidism can have dyslipidemia, high triglyceride levels, and low HDL cholesterol levels, normostic or macrostic anemia, infrequently hyponatremia, and rarely in some patients elevated creatine kinase with myopathy. It's also known as Coher-Debret-Semelin syndrome. Primary hypothyroidism may be associated with enlarged ocella turcica resulting from the secondary hyperplasia of thyroid cells. It can be discovered when the cranial imaging is performed for evaluation of short stature. Although pituitary enlargement may be rather pronounced, it rarely causes symptoms or things, and it is reversible with levothyroxine therapy. Occasionally, patients with severe hypothyroidism develop pericardial and pleural effusions, which may be presenting features. Skeletal maturation is usually delayed, and we can see it during the assessment of bone age. You can see the causes of the hypothyroidism in children and adolescents in this table. Autoimmune thyroiditis, also known as Hashimoto thyroiditis or chronic lymphocytic thyroiditis, is the most common cause of the acquired hypothyroidism. Typically presents with erythroid goiter, but can be present with overt hypothyroidism. Approximately 2 times more frequent in the females, and some chromosomal disorders like trisomy 21, Turner syndrome, Klinefelter syndrome, and some autoimmune disorders like type 1 diabetes, celiac disease, autoimmune polygonal syndromes, and IPEX syndromes are associated with autoimmune thyroiditis. Hashitoxicosis and subacute granulomatous thyroiditis are the disorders with a short course of hypothyroidism followed by transient hypothyroidism. Iodine deficiency, the most common cause of the hypothyroidism worldwide, apart from the developed countries. But in developed countries, use of the non-iodinized salt by choice, prolonged parenteral nutrition without iodine supplement, use of enteral formulas with low iodine concentration can cause the hypothyroidism. A spot and 24-hour urinary iodine measurement will be help to diagnosis. Multiple drugs via multiple mechanisms can cause the hypothyroidism. Treatment of the hypothyroidism, such as Graves' disease, can cause the post-ablative hypothyroidism by subtotal thyroidectomy, radioactive iodine, or treatment of the oncologic disease can cause the hypothyroidism after external neck and craniospinal irradiation. Cystinosis and Langerhans cell histostosis, which are the infiltrative disease, can infiltrate the thyroid gland and cause the acquired hypothyroidism. Langerhans cell histostosis also can cause the central hypothyroidism. Both thyroid dyskinesis and inborn errors of the thyroid hormone synthesis may appear to be acquired hypothyroidism if the defect is not severe. Like DiGeorge syndrome, Williams syndrome, Prader-Willi syndrome, and pseudohypoparathyroidism type 1A and 1B can be associated with acquired hypothyroidism. All children with acquired hypothyroidism should be will be checked for the clinical features of these syndromes. Large liver hemangiomas in infancy and in young children can cause the hypothyroidism because there is high level of type 3 deiodinase activities in these hemangiomas, and T4 convert to reverse T3. Thyroid hormone resistance, in patients with thyroid hormone resistance, they are usually erythroid, but may have some tissue-specific manifestation of hypothyroidism or hyperthyroidism. Central hypothyroidism, hypothalamic or pituitary tumors can cause the central hypothyroidism, the most common of which is the craniopharyngioma, and direct effect of tumors or as a result of therapy can be caused the central hypothyroidism. And also Langerhans cell histostosis and congenital defects like septo-optic dysplasia. If a child with isolated TSH deficiency, we take account some gene mutations like IGSF1 and TSH beta subunit or TRH receptor mutations. What should we do after the diagnosis of the hypothyroidism by thyroid function test? If children with primary hypothyroidism non-obese children with subclinic hypothyroidism, or obese children with subclinic hypothyroidism if TSH above 7.5 or 10 millunit per liter. We recommended measuring TPO and thyroglobulin antibodies because of the possibility of the autoimmune thyroiditis. Also, we recommended perform a thyroid ultrasound. Near 10% of children with autoimmune thyroiditis have no antibodies. Mild elevations of TSH are common in obese children and may not warrant antibody testing, as well as thyroid ultrasound if free T4 is normal. If children have central hypothyroidism, we should perform a cranial imaging, preferably MRI, and test for other pituitary hormone deficiencies. I would like to present two cases with acquired hypothyroidism. First patient is a boy, 15 years old. His weight is normal, height is below the 3 centiles, minus 4.2 SDS, weight for height and BMI increased. His complaint is increase in weight gain, short stature, weight gain for the last 3 to 4 years despite usual nutrition, and physical examination revealed vital things are in normal range, mental state is fine, no goiter. He has puffy face, dry skin, coarse hair, and white patches on the skin, which diagnosed with as vitiligo, and his puberty is delayed. Laboratory tests showed primary hypothyroidism with high level of thyroid antibodies, thyroid ultrasonography revealed atrophic thyroid gland, and bone age was 10 years and 6 months. The diagnosis is autoimmune thyroiditis. Because of the skeletal maturation slows or cease after the onset of the hypothyroidism, the bone age may indicate the age of onset, and for this reason we can say the disease of these children starts when he was 10.5 years old. This child is another victim of the congenital hypothyroidism, such as the previous presentation. She was 8 years old, girl, and when she admitted to clinic, she cannot speak, she cannot walk independently. Actually, she has diagnosed with congenital hypothyroidism after birth, and she received for a short time levothyroxine treatment, and then after her parents stopped the treatment. Our second patient is another girl. She also has a approximately same size. Both of height is about 82 centimeters. She presented because of failure to thrive. She was small since infancy, has stopped growing for at last 2 years. She born in term, birth weight was 1/250. Physical examination revealed normal vital signs. Mental state is fine, no any development delay, no goiter. She was prepubertal. She speaks very fluently. She is a smart girl. Laboratory tests revealed primary hypothyroidism, high thyroid antibodies. She has also have tissue transglutaminase immunoglobulin A positivity, and she was born age 2 years 6 months. She diagnosed with CGH, celiac disease, and autoimmune thyroiditis. She is an unlucky girl. Why these girls haven't any motor mental retardation and motor retardation? Because his disease start after the 2 years of the age. Indications for levothyroxine treatments are primary hypothyroidism, central hypothyroidism, and subclinical hypothyroidism if TSH levels above the 10 millunit per liter. Also, consider treatment in children with mild subclinic hypothyroidism, which TSH 6 to 10 if there are clinical features likely to be associated with hypothyroidism. These are decreasing height velocity, presence of goiter, positive anti-thyroid antibodies, metabolic complications such as dyslipidemia. The dose of levothyroxine can be set by age of the patients. In patients age 1 to 3 years, 4 to 6 microgram, 3 to 10 years, 3 to 5, 10 to 16, 2 to 4 microgram per kilogram of body weight. Independent of the age, 100 microgram per meter square of body surface can use for dose of the levothyroxine, a single day dose. How we monitor and adjust dose of these patients? Check TSH and free T for 6 to 12 weeks after the initiation of treatment or any dose change, and then after check TSH, free T for every 6 to 12 months. The target of the treatment is bring to TSH the lower 1/2 of the reference range and free T for the upper 1/2, as long as if both of them are in the reference range, we judge the dose is enough. For children with central hypothyroidism, the target of the treatment is bring free T4 to upper 1/2. At admission, if TSH in the normal reference range, the TSH will become lower than the reference range. And if at the admission TSH is lower than reference range, we don't use for follow-up. The key point is the possibility of the concomitant central adrenal insufficiency with central hypothyroidism. If this is the case, the glucocorticoid replacement should always precede thyroid hormone replacement. Continue treatment until growth and puberty complete, and then regulate the thyroid function. At that time, it can be addressed by discontinuing levothyroxine and measuring serum TSH 1 month later. Last 2 slides for take-home messages. Acquired hypothyroidism is most common abnormality of thyroid function in children and is most often caused by autoimmune thyroiditis. Many children with acquired hypothyroidism, particularly those with subclinical hypothyroidism, will be asymptomatic. In those with overt disease, clinical features include declining high velocity, short stature, and or the presence of the goiter. Adolescents may also have signs of pubertal delay. When acquired hypothyroidism is suspected, serum TSH and free T4 should be measured and compared with age-specific normal values. If another etiology is not obvious, testing for TPO and triglobulin antibodies and performing thyroid ultrasonography is recommended. Mild elevation of TSH in obese children is common, is a consequence of the obesity and by itself does not warrant thyroid hormone replacement. To restore normal growth and development and correct associated clinical manifestations, patients with clinical and laboratory evidence of hypothyroidism require replacement therapy with levothyroxine. Treatment for patients with subclinical hypothyroidism is also suggested. And once growth and pubertal development are complete, treatment can be discontinued and thyroid function regulated. Thank you for attention.
Okay, thank you, Dr. Ehsan. That was a very lucid talk. There are a few questions for you in the question and answer. I would like to take one, and then I would request you, if you have time, you can just reply it in the question and answer.
Okay.
Isolated TSH deficiency, that is IGS F1 mutation, as you mentioned. The doctor wants to ask, how is the natural history and do they require lifelong replacement? And also, do they require brain imaging if mutation is confirmed and cortisol growth velocity is normal?
First, in IGSF1 mutations, the hypothyroidism is not more severe and can be diagnosed in the during the adolescence and the later age of the childhood. Yes, when we diagnose with the hypothyroidism, we should treat with the levothyroxines, and this is usually lifelong therapy. I would like to remember another feature of these patients is macroorchidia can be seen in the boys with these mutations. And the second question, sorry, can you remember it? It's about the cranial imaging.
Do they require brain imaging if mutation is confirmed? And
no.
Are normal.
If the mutation is confirmed, the cranial imaging is not should performed.
Okay, thanks a lot. Thank you very much for a very nice talk. And if they have time, please do answer the questions in the chat box. Over to Dr. Tomash. I think Dr. Tom. So thank you. Let's move on to our next talk. We have a session on it's a panel discussion. So we have a very esteemed for this. I invite Dr. Rajni. Just a minute. I invite Dr. Rajni. She is the senior. She's a consultant at All India Institute of Medical Sciences, looking after the pediatric endocrinology department. And she has multiple publications to her credit, and she was a former joint secretary at ISPE. We have an esteemed faculty with her, Dr. Anju Seth, Dr. Amarnath, he's from Pune. Then we have Dr. Medha Mittal and Dr. Divya Lakshmi. I request Dr. Rajni to take over, and you can give a brief introduction of the panelists. Thank you.
Thank you, Dr. Richa. And I'd like to thank Indian Academy of Pediatrics, North Delhi, for the invitation. Should I show my slides and share the screen?
Yeah, you can.
Can you see the slides?
Yes, we can see your slides. You can start the slides.
Thank you. So now we'll start our panel discussion. It's a very important topic on bone disease in children, which we see quite often. And I have a very esteemed panel, which Dr. Richa has already introduced. So without much time, I'll just start the session. So bone is basically made up of matrix, which consists of the organic osteoid, which is 40%, mostly collagen, and the mineral content, which is hydroxyapatite, up to 60%. So there are two main conditions. One is osteomalacia, and in children, osteomalacia manifests as rickets, which is due to the lack of mineralization of cartilage and bone matrix. And the second condition is known as osteoporosis, which is due to generalized paucity of bone. Both the osteoid and mineral are deficient. So what is important to remember is that both conditions, rickets as well as osteoporosis, can lead to an increased risk of fracture. So we go on to a case, a 1.5-year-old boy with bony deformities, which are very common in our OPD scenario, well-nourished, irritable, with wide open AF. From head to toe, he has a wide open AF, frontoparietal bossing, beading of ribs, rachitic rosary, wrist widening, double malleoli. Rest of the systemic examination is normal. So we would like to start by asking, what are the relevant points in history and examination in this case? And what are the investigations we should do? Dr. Amarnath, please.
Good afternoon, all. Thank you very much for this opportunity. So I would like to thank Dr. Rajni and Dr. Richa for giving this opportunity. We know most common cause of rickets is nutritional, but I am going to cover history for all the types. So coming to the starting from the antenatal onset, there should be sufficient supplementation of vitamin D to the mother, so that, and whether it's a term delivery, preterm deliveries are babies are more prone for rickets. And again, come to the exclusively breastfed or not, and early weaning and late weaning both can cause vitamin D deficiency and vitamin D supplementation. So normally we have to give up to 1 year of age. And also coming to the dietary history, most common cause of rickets is nutritional. So we have to take detailed history of calcium and vitamin D, which is going to be covered in our next slides. And coming to the systemic disease of the liver, pancreas, and kidney, skin can cause. So take this history. and ask for the growth. So whether child is growing well or not. And coming to the developmental history, we have to ask about the mainly motor developmental delay we commonly see in nutritional rickets or any types of rickets, and also hypocalcemic seizures. It's a very important thing. So severe vitamin D deficiency can present with seizures, and which needs admission. And drug intake, mainly anticonvulsants, steroids, and also any other drugs, and history of previous vitamin D supplementation, either oral or parental. It's very, very important. Coming to the, and in India, we know poverty and malnutrition also plays very important. Family history plays important role only in resistant rickets like hypoplasmic rickets or vitamin D resistant rickets, the VDDR1 or 2. So examination already Rajni has mentioned. So F will be wide open, large head, frontal bossing, wrist widening, rachitic rosary, Harrison sulcus, double malleoli, bowed legs, motor delay. If you examine, there can be hypotonia and biseptosis. Short stature can be there. Initially, there is a proportionate short stature, and later it can cause increased upper segment, lower segment ratio. Most important investigation, all we know, calcium phosphorus ALP is very important. ALP more than 2 times the normal value is significant. So wherever the resource settings in PHC, we have to do X-ray wrist along with this calcium phosphorus ALP is enough. But wherever is possible, please do 25-hydroxy vitamin D. It's a most important investigation. We're going to discuss in next slides. PTH and pH, ABG or VBG, and serum creatinine, urine for amino acids and glucose for RTA or Fanconi's, and growth chart. Can we go for next slide, please? X-ray findings, we see there will be increased gap between the metaphysis and epiphysis, more specific for the rickets, and cupping and fraying. Here you are able to see, and also you can see going up the legs and rachitic rosary if you take the X-ray chest. Yeah, right side you are able to see normal X-ray, left side you are able to see the X-ray. And you can see in severe rickets, there can be even osteoporosis also can be there.
Okay, thank you, Dr. Amarnath. So these are the normal values of vitamin D. If we do the levels, which as Dr. Amarnath has rightly mentioned, we should do where available. Otherwise, vitamin D and PTH are not actually necessary in all cases of nutritional rickets. So the adequate levels, this is according to the recent global consensus recommendations on prevention and management of nutritional rickets. Less than 12 nanogram per ml of vitamin D is considered deficient. 12 to 20 nanogram per ml is considered insufficient, and greater than 20 nanogram per ml is sufficient for bone health and prevention of rickets. Anything more than 100 nanogram per ml is considered toxic range. And there is a conversion, you multiply by 2.5 to get the value in nanomoles per liter. So some adult guidelines would mention more than 30 nanogram per ml as normal, as sufficient, but in children, greater than 20 nanogram per ml is taken as sufficient. So what is the treatment of nutritional rickets in such a case? And what are your comments on STOS therapy, that is the mega therapy of vitamin D? I'd like to invite Professor Anju Seth. Ma'am.
Good evening, friends. Rajni, am I audible?
Yes, ma'am, you're audible.
Okay. Good evening, friends, and thank you, Dr. Rajni. Let's first look at the principles of treatment of nutritional rickets. As we know, rickets is primarily caused by deficiency of vitamin D and calcium, and the relative contribution of each may vary in an individual case. Therefore, when we treat, we look at a comprehensive treatment which includes both vitamin D and calcium. The minimum recommended dose of vitamin D is equivalent of 2000 international unit daily. It varies a little with age, as I'll show, and the treatment duration is minimum of 6 to 12 weeks, though some children may require longer, followed by maintenance therapy. And oral calcium, either as a dietary intake or supplement, should be given. And of course, one should keep in mind, especially if a new child comes to us in the OPD, inquire about previous administration of calcium and vitamin D, because sometimes patients with refractory rickets who do not respond do tend to go to various doctors. And we also, that would also be important to monitor response to therapy. Next slide, please, Dr. Rajni. Next slide, please.
Actually, the slide is not moving. I'm just trying. Yes.
Okay, so a crowded slide. The idea is to show that even though it's such a common disorder, we have as many recommendations on treatment. The one that we follow widely are the global consensus recommendations that came out in 2016. The Indian Academy of Pediatrics followed that in 2017. And right now also IAP is in the process of revising these guidelines because so much of evidence has changed in the field of vitamin D. So if we look at the column, the middle column, the global consensus recommendation, for infants, what is recommended is 2000 units per day for 12 weeks, followed by a maintenance of 400 IU per day. For a child beyond 12 months to 12 years, the daily dose goes to a little higher, 3000 to 6000 international unit per day. The duration remains the same. And for children beyond 12 years, 6000 IU per day. Global consensus guidelines widely recommends use of daily therapy. The bolus therapy has absolutely no use in children less than 3 months. Even beyond that, they are wary of recommending anything more than 50,000 IU single bolus in infancy because of want of evidence. We'll talk about this in the subsequent slide. But the bolus dose should not exceed 1.5 lakh unit in children beyond 1 month to 12 years and more than 12 years, not beyond 3 lakh unit. Can we go to the next slide, Dr. Rajni? And as I said, always combined with calcium. Your next question was related to the large dose of the STOS therapy. So this is when we grew up as students, this is what we were thought was the standard guideline for treating rickets, giving 6 lakh international unit. Even the sachets that contain now 60,000 unit, when we were residents, they came as 6 lakh unit. So 6 lakh was the standard dose that was used. However, our guidelines have evolved and actually helped a lot by wide availability of 25-hydroxy vitamin D assays, which have helped us, understand what the doses are doing, those large doses are doing to the body. So as far as current evidence is concerned, it has shown reasonably clearly that single mega doses are not only not required, they may actually be harmful. I'm not going to be quoting individual study here. There are multiple studies, including one from my own center, where we did find that these kind of doses tend to lead to unpredictable kind of a response. So some children may actually go on to develop hypervitaminosis D and develop hypercalcemia and hypercalciuria. And in another study from UCMS, the authors actually proved that 3 lakh unit was as good as 6 lakh unit, but both led to hypercalcemia. So to summarize, really it's time that we firmly stopped using that 6 lakh unit bolus dosing from our current practice. Just next slide, Dr. Rajni. What about the sachets? We get 60,000 sachets. They are so convenient to use and they are way more economical as compared to daily therapy, at least as of now. All of us have been using them. But if we look at the strict evidence, there is actually not much evidence of safety of any regime, including 60,000 IU weekly that IAP recommends, other than daily administration. In fact, the current thinking that seems to be evolving that if you give any form of bolus doses, it leads to an unpredictable kind of a rise in vitamin D, in 25-hydroxy vitamin D levels, whereas daily dosing leads to a slow, steady, and a maintained rise. There are studies which have shown that if you give intermittent doses, the levels tend to decline very fast. So if you give a big dose initially and in one group and to the other gets the same equivalent dose but spread over days over daily dosing, the ones on daily dosing do better. But this is an area of research gap and where a lot of people I'm sure are working, and certainly we are also working on this area, how good those 60,000 sachets are versus daily therapy. But yes, we have been using it. Carry on, please.
Okay, thank you, ma'am. So it's very clear from what ma'am has said that we should ideally be using the daily therapy, and it's very essential to give daily calcium as well. So how would you follow up this patient after treatment?
Thank you, Dr. Rajni and Dr. Richa, for the wonderful opportunity. So to answer the question, to say that is there any
think your voice is
consensus?
breaking.
Yeah, am I audible?
Yes, you are audible.
Yeah, okay.
Back. Okay. Yeah, you can continue.
Okay. So there is as such no consensus towards monitoring these patients. But however, I feel like most of the centers in our country, they agree measuring biochemical and as well as doing a radiological assay by about 4 to 6 weeks of age in order to assess the response in these children. But these investigations like need not be done later than 12 weeks because it is of no use. And if we see a poor response, like the calcium, phosphorus, alkaline phosphatase are not getting normalized, or there is no provisional zone of calcification in the X-ray, I think it is by then, even by at 12 weeks, if there is no response, but then like we need to think about non-nutritional causes like resistant rickets or dependent rickets. I mean, in what I meant is like hypophosphatemic rickets or something like that we have to evaluate. So in this case, we need to measure 25-hydroxyvitamin D intact PTH and as well as 125-dihydroxyvitamin D. And also we need to decide like whether we need to continue on the therapy that we have given for the nutritional rickets. So for those children who had a good response following a vitamin D therapy, we should follow them up periodically in order to ensure that calcium, phosphorus, vitamin D levels were in the normal range. And during the monitoring, like at any point of time, if 25-hydroxyvitamin D levels are more than 100 nanogram per ml, these children needs to be monitored for hypercalcemia and as well as hypercalciuria. So coming to the response, how to assess the response aspect of rickets. So the first thing to get normalized is the serum phosphorus level, which normalizes by 96 hours. And the rise in serum calcium, we can appreciate by about a week after starting therapy. And fall in the alkaline phosphatase level and also radiological response, we can appreciate it by 3 to 4 weeks of therapy. And any physical deformity that we have noted in this child might take like months to years, even after starting therapy. Most of these deformities can get corrected with growth. In rare cases like severe deformities, etc., like may require some orthopedical intervention. Hence, it may be necessary to monitor these children at 4 to 6 weeks for the initial response. As you can see in this child, like there is good amount of calcification along with the zone of provisional zone of calcification, and it may be mandatory to continue for longer duration of treatment as well in some patients in order to ensure that there is a complete healing radiologically. And this is, I think, the same case prior to therapy and following therapy. As you can see how well the calcification has occurred along with the provisional zone of calcification. Even here in the metacarpals, we can appreciate the same amount of calcification that has occurred. Next slide.
Thank you, Dr. Divya. Regarding the prevention of vitamin D, are there any high-risk groups that require supplementation with vitamin D to prevent nutritional rickets? Dr. Medha? You can unmute yourself.
Thank you, Dr. Rajni. All infants need supplementation. As we know, infants are a vulnerable group as they are growing fast. And there is evidence to show that vitamin D deficiency is very common in this age group, and they are at high risk to develop vitamin D deficiency and its consequences. Beyond 12 months of age, supplementation is required for those who have symptomatic vitamin D deficiency and children who are at risk to develop vitamin D deficiency because of their medical conditions. Next, please. So beyond infancy, we should test and treat those children who are at high risk of developing vitamin D deficiency because of their disease states, such as malabsorption states, which impairs the vitamin D absorption. Children on anti-epileptic drugs that will increase the metabolism. Children who are non-ambulatory, such as those with cerebral palsy or neurodegenerative disease, where there is no ambulation, their intake may be low and they are nutritionally deprived. Next, please. So how to prevent this vitamin D deficiency in infancy? The best way is to supplement the mothers during pregnancy. So So all pregnant mothers should receive vitamin D supplementation in doses of 600 international units per day, and the adequate maternal 25-hydroxy D levels will prevent neonatal hypocalcemia and congenital rickets. Although this 25-hydroxy D of the maternal levels may not increase the bone mass or the bone length, but it will definitely improve the incidence of neonatal hypocalcemia and prevent congenital rickets. So, all pregnant women and infants need supplementation, and without testing for deficiency, we should supplement them. The high-risk children need to be screened and supplemented as required. There are no known benefits of supplementing or treating apparently healthy children. So there is no need to perform a routine vitamin D test for apparently healthy children or children with non-specific complaints to identify any vitamin D deficiency or attribute these complaints to it.
Thank you, Dr. Medha. So that's a very important message that we should not be doing routine vitamin D testing in all in non-high risk patients. So what are the recommendations for calcium intake to prevent rickets? Is there any minimum amount of calcium that children should be taking so that they don't have bone disease? And many times patients come into the OPD with a report of vitamin D, which is in the insufficient range. So how should these cases be treated? Dr. Anju Seth, ma'am?
Thank you, Dr. Rajni. Can you show the next slide? So it's from a lot of research across the country, it is quite obvious that there is widespread dietary calcium intake deficiency in India, and this is it is in all age groups, and even in urban families and affluent families. It's like the poor people cannot afford, and the rich ones will not have it by choice. So that's an unfortunate state of affairs. But calcium is really important. Vitamin D will nothing if there is no calcium. So we need to stress upon calcium intake, and ideal, of course, is that it should take place through normal diet. But if a patient has rickets and if we are not too sure of dietary intake of calcium, it does make sense to supplement calcium in every case with rickets. And these are the standard recommendations for minimum calcium intake for every age group. And I think in general, for a child beyond infancy, at least 500 milligram of calcium per day is needed. And if it is less than 300 milligram, that is clearly deficient. I think I cannot repeat it often enough. Rickets cannot be prevented or treated if calcium deficiency exists.
And next how slide. Much dairy product would that be, ma'am? 500 mg?
About very rough, a person should take at least 500 ml of milk or its equivalent every day. And that should give us adequate calcium. Next, please. And yeah. So you raised a very important point. I'll take off from where Medha took off. This problem of treating asymptomatic deficiency, you're stuck with the report, and increasingly we see it, and it's a problem. What do you do with it? And what I'm saying here comes more from logical sense, and whatever little evidence exists, honestly, not much evidence exists. So I would say if you pick up any deficiency in infant, makes sense to treat it, I would say. They are very vulnerable, they're growing fast, they can develop hypocalcemic seizures or rickets. And we do know that symptomatic vitamin D deficiency in children is very, very common in infants. So we should go ahead and treat that. For the same reason, I would maybe stretch myself and say asymptomatic deficiency, if I pick up in adolescents, I'll feel a little uncomfortable not treating it for its possible long-term impact on bone health. Again, no evidence here, please. So, but both these groups are vulnerable. Therefore, it makes sense. If you pick up some deficiency, makes sense to treat it. The third group I would like to treat is children with associated comorbidities that increase the risk of vitamin D deficiency. That has already been alluded to, the malabsorption state, CLD, renal efficiency, insufficiency, children on anti-epileptics. Again, for the reason that these children are more vulnerable and may develop symptoms related to vitamin D deficiency, might consider treating it. What would I not treat? Can you go on to the next slide? So any other children apart from the ones I have mentioned, actually there is no need. Ideally, the situation should not arise. Why should we be testing healthy children anyway for vitamin D deficiency? Secondly, because there are no symptoms, how are we going to assess the benefits of treatment? So are you treating a number, one report, you give something and you look at another report? What is the benefit of that? A real danger is missing another serious diagnosis if low vitamin D level is ascribed causality for non-specific complaints. I do remember, Rajni, you might also remember cases from Kalavati Saran Children's Hospital presenting with bone pains, treated as rickets and ultimately turning out to have leukemia. What could be a bigger disaster than that? So ascribing, bone pains and non-specific symptoms to vitamin D deficiency, whereas the underlying cause goes unrecognized, is a real danger. And honestly, there is no evidence anywhere, no studies to guide doses or regime in asymptomatic individuals. We do not know where to begin, where to end. And there is a high chance, and there is evidence of that, high chance that the deficient state will recur once treatment is stopped, unless supplementation is continued. So you give treatment, you got a asymptomatic child, you give him treatment, the numbers become great. He was asymptomatic earlier, he is asymptomatic now. You stop the treatment, over some time the levels fall again. So what have you achieved? But if you continue to give him vitamin D, what are you doing to him? You might actually increase his chances of developing serious problems like hypercalciuria and nephrocalcinosis. So we need to keep all that in mind when we think of treating asymptomatic deficiency in any groups other than the ones I've mentioned. That's it. Dr.
Thank you, ma'am. Yes, ma'am. And these patients you would treat with daily therapy, ideally the ones who are high risk and the infants and
again, we are going into areas where there is not enough evidence. So I would say if we have to treat them, then let us follow the treatment guidelines that exist. There is no evidence that they would require any treatment different from those. So whether we are giving them daily or we are using some formulation of 60,000 and using that 60,000 weekly or 60,000 monthly equivalent of those diseases, no evidence exists. At least no published evidence. I know a lot of us are working on it, but I don't see any reason why the treatment should be any different.
Thank you, ma'am. Regarding the prevention of rickets, is there any recommendation for sunlight that for Indian people, Dr. Amarnath?
Yeah, thank you, Rajni. In previous question, I forgot to tell about the hypocalcemia. Any hypocalcemic seizures associated with vitamin D deficiency should be admitted. You should be treated with IV calcium or Rocaltrol, then followed by normal vitamin D. Coming to the sunlight. So we always give vitamin D, but forget about two things. One is diet, second is sunlight. This should be stressed again and again. And sunlight depends on the various factors. The amount of surface area, body surface area exposed. It may vary from 10 to 90%. So minimum, it should be 40%. It's a sunlight vitamin. So 11 a.m. to 3 p.m. is the best time to expose. In Southeast Asians, the double time is required. Normally 10 to 20 minutes every day for 5 days in a week is required. For us, Southeast Asians, it's better to 20 to 30 minutes within 5 days a week is good. And yeah, this is called zenith angle, where the maximum sunlight is exposed. And also it depends on the winter or summer. Summer it is less and winter it should be more. And for deficient people and insufficient people, the sunlight exposure should be more. Thank you.
Thank you, Dr. Manath. What are the causes of refractory rickets? Now, suppose this patient after 4 to 6 weeks, we see he's not responding. And even after the upper limit of 12 weeks, he has not responded biochemically or radiologically. So what are the causes of refractory rickets and what are the clinical pointers to non-nutritional rickets? Dr. Medha?
Yes. Once we find that the child has not responded to the usual vitamin D therapy and he has come to us and follow up, and we find that the biochemical parameters still suggest active rickets. So we have to look for other clinically also. The other causes should be looked for, such as hypophosphatemia, where there is renal phosphate wasting or a genetic mutation causing it. Vitamin D dependence, where the 1-alpha hydroxylation step is impaired or the receptor resistance is present. Renal tubular acidosis, again causing phosphate wasting. Liver disease, impairing the 25 hydroxylation step. Malabsorption, impairing the vitamin D absorption from the gut. Or chronic renal failure, where the 1-alpha hydroxylation step is impaired. We should carefully look for these diseases and follow the criteria required for them.
RTA can be both proximal and distal.
Yeah. For renal tubular acidosis, we should look for acidosis and blood gas. We should examine the urine pH and calculate the bicarbonate excretion. If the urine pH is more than 5.5, This means the acidification is impaired and it could be pointing towards distal RTA. If the urine is acidic below 5.5, then it may point towards proximal RTA. So all these things should be carefully looked for and assessed for phosphaturia by calculating the renal phosphate absorption index, TMPO4. Next, please. We should clinically look for the pointers that may point towards non-nutritional rickets. First and foremost, when we repeat an X-ray, we find that there is no radiological healing even after three months. Deformities, severe deformities, especially of the lower limb, can lead us to think for and look for hypophosphatemia. Here, the lower limb is more affected than the upper limb. We should look for features of underlying disease states such as chronic kidney disease, liver disease, celiac disease or malabsorption, features of renal tubuloacidosis such as polyuria, polydipsia. The child may have failure to thrive and muscle weakness. We should carefully ask for a family history and ask for consanguinity. Presence of dental abscess and alopecia should be carefully looked for. And alopecia is frequently having alopecia totalis, and this may point towards vitamin D dependent rickets, type 2. So this was a family of 3 girls that came to us. And if you see all 3 of them, this is this girl having severe lower limb deformities. And this girl also undressed here, also having severe lower limb deformities. So there was something in the running in the family, an inheritable cause that caused the 3 siblings to have severe lower limb deformities, and this pointed towards hypophosphatemic rickets.
Thank you, Dr. Medha. So we've learned very important point of how to suspect non-nutritional cause of rickets. Now we'll go on to other case, that is osteoporosis. We have a patient, 12-year-old with history of recurrent fractures. He had right forearm radius bone fracture 2 months back while playing, and another fracture of left tibia while playing football. So what is the definition of pediatric osteoporosis, and would he fall into the definition of pediatric osteoporosis? Professor Anju Seth?
Thank you, Rajni. So definition of osteoporosis in children is a little different from what you use in adults. In both, of course, it is based upon assessment of bone mineral density. While in adults, we use something known as T-score. And T-score actually refers to the standard deviations below the mean peak value for a young adult of that gender. So what is the highest achievable BMD for a young adult of that gender? If the BMD is less than 2.5 standard deviations, then that is considered osteoporosis. And if it's between 1.1 to 2.4, it is osteopenia. Now, in children, we do not use T-score for the reason being that bone mineral density depends upon the age of the child. Therefore, like for the way we have norms for weight and height and BMI, we also have norms for bone mineral density in children. And we use those normative data to define osteoporosis. Accordingly, low bone mass, that is less than minus 2.5 Z score instead of T score, for gender, age, height, and pubertal stage is considered as low bone mineral density. And by Z scores, of course, I mean if it is 2.5 standard deviations less than what is normal for that particular gender, age, height, and pubertal stage. But it's not enough to use only presence of low bone mass, but also evidence of fractures. While WHO uses presence of low impact fracture as a term, can I have the next slide? The International Society for Clinical Densitometry would use occurrence of clinically significant fracture term, which means 2 or more long bone fractures occurring by 10 years of age, or 3 or more long bone fractures at any age up to 19 years of age. However, this definition also includes if there is 1 or more vertebral fracture, even in absence of local disease or high energy trauma, that by itself is adequate to classify a patient as having a bone fragility state, because the vertebral fractures in absence of that are distinctly uncommon. So that's it, Dr. Rajni. I think, yeah, this I thought we could just quickly, because we're talking about this, let us just have a very quick look at what are the factors that affect bone mineralization. And because there is so much of emphasis these days how to prevent that osteoporosis, we should keep in mind that huge chunk actually comes from heritable factors. So accounting for nearly 60 to 80% of bone mass, over which an individual may not have much control. But what we have a control on are the next ones. The nutrition, which is not only calcium and vitamin D, but also adequate amount of proteins and some minerals, other minerals and vitamins. Body mass, there is a definite positive correlation between lean body mass and bone mineral density, whereas obesity has an adverse impact upon BMD. So, and weight bearing exercises, even simple weight bearing exercises, running, jumping, skipping, are shown to have a good impact on bone mineral density. And yet, so these are very easily modifiable factors, which we can easily use to prevent osteoporosis in children. And of course, very important is hormonal milieu. The most important hormones being sex hormones. Others are also important, like growth hormone. But sex hormone is perhaps the most important among these. That's it, Dr. Rajni. Dr. Rajni,
Sorry,
you're muted. Yeah.
Yes, sorry, it got muted. So as we learned, thank you, ma'am. It's very important to maintain nutrition as well as to do weight-bearing exercises to maintain bone mass. So what are the causes of pediatric osteoporosis in a patient whom you think to have pediatric osteoporosis? Dr. Divya?
Thank you, ma'am. We can broadly classify the etiologies into primary and secondary. So among the primary causes, the most important one is osteogenesis imperfecta. There are approximately about 14 types in it, and the next common will be inherited forms of rickets, and the least important causes are like hypophosphatasia, idiopathic juvenile osteoporosis, and then metabolic causes like homocystinuria and etc. And in the secondary causes, I think these I feel like in particular are more important because nutritional, like vitamin D, calcium deficiency, malabsorption states, and then endocrine conditions sex steroid deficiency, hypogonadism, and PTH excess, hyperparathyroidism, and then immobilization in, for example, in children with cerebral palsy or Duchenne muscular dystrophy. Inflammatory diseases like juvenile idiopathic arthritis, dermatomyositis, etc. And then drug induced, I think importance needs to be given on corticosteroids, anti-epileptics, etc. And children with the chronic illnesses, also hemoglobinopathies, etc., also are at increased risk of getting pediatric osteoporosis.
So these are the very important causes, especially secondary causes are very important. And then come the primary causes. So how would you approach this case, Dr. Divya?
So as like I would approach any child who comes with a non-specific bony pains or like that. So I would do a bone mineral profile, which consists of like a calcium, phosphorus, alkaline phosphatase, 25 hydroxyvitamin D, and intact PTH. So DEXA scan whenever possible. Like I think it's a must. It helps us in deciding on therapy. In places where DEXA scan is not available, I think doing an X-ray DL spine is a must in order to look for vertebral fracture, because many patients they tend to have some mild grade of backache, and they may not even inform us unless we look into actually. So these are the investigations perspectives I would do for a child in whom we suspect osteoporosis. And treatment aspects, it's to correct the underlying illnesses, like CKD or malabsorption or like steroid intake or so. And also if there is vitamin D deficiency or a calcium deficiency, we need to correct that. These children, they need to be supplemented like daily calcium and vitamin D. Calcium, as according to the age, varies. It can be 600 to 800 milligram per day. So vitamin D supplementation for less than 1 year we give 400 IU per day, and like more than 1 year we give like 600 IU per day. If despite our management, if the child is continuing to be symptomatic or not responding to our vitamin D and calcium supplementation, then giving bisphosphonates will help.
So
bisphosphonates
are a very important category of drugs which are anti-osteoclastic, which have anti-osteoclastic activity and can be useful in osteoporosis, which is not responding. So when we do bone mineral density by DEXA scan in children, are there any precautions that we have to take and which body part is preferred? Dr. Amarnath?
Thank you, Rajni. As already Divya Lakshmi and Professor Anju Seth has covered. So most commonly, we do X-ray. To see changes in X-ray, there should be 30% bone loss should be there. And there are other methods which are quantitative ultrasound, PQCT, macro MRI. The expectation is not there. So children below 2 years, preferred one is whole body without head, and more than 2 years, whole body without head with lumbar spine. And in case of children who are like cerebral palsy or not able to get up and all, preferred one is femur. And along with the bone mineral density, we are able to see the bone mass. If muscle mass. If muscle mass is low, you should think of secondary osteoporosis. Thank you.
Okay. Thank you. So now we have this 13-year-old girl with multiple sclerosis who has received multiple courses of steroid therapy. And as we have learned that prolonged steroid is a very important cause of osteoporosis. And now she complains of severe backache. And the X-ray of lumbar spine shows collapsed L2 vertebra with osteopenia. So she has steroid-induced osteoporosis, which is very common in our scenario. So how would you treat and prevent steroid-induced osteoporosis, Dr. Medha?
Thank you, Dr. Rajni. At the beginning of the treatment and subsequently every year, we should do a clinical estimate to assess any risk of fracture. So a clinical fracture risk assessment at the start of treatment and every 12 months thereafter. Also, we should ensure that children taking glucocorticoids should have a good intake of calcium, about 1000 milligram per day, and vitamin D, 600 international unit per day. If this child does have an osteoporotic fracture and he does need glucocorticoid to be continued at doses of 0.1 mg per kg per day, we should add bisphosphonates. Besides, all along the therapy, we must encourage good physical activity to ensure a good physical health, good bone health.
Thank you. And any precautions?
Also, we should ensure that we use steroid with lowest potency at the lowest effective dose and taper as early as possible. Switch to alternate day when possible. And at every visit, screen for clinical features of complications. Do a calcium profile, electrolytes, and blood sugar every 6 months, and a bone mineral density every year.
Thank you, Dr. Medha. Now we're reaching the end. I would request Professor Anju Seth to please tell us what are the preventions for osteoporosis in high-risk categories of children.
Thank you, Rajni. Can I have the slide? First, what are the general principles? Yes, the general principles. And these are applicable for prevention in all children. So even healthy children, adolescents and young children, remember adolescence is the time when maximum bone mass is being accreted. And that's the time once it's a critical factor that will prevent osteoporosis later on in life. So the key general principles are what I mentioned in the determinants earlier of bone health. Healthy eating, which includes adequate calcium, vitamin D, protein, avoiding excess caffeine, tobacco, cola, and alcohol. Now the generation, we need to talk of that also. So coffee and cola are the two major diet factors which have a negative influence. Apart from that, maintaining optimum weight and regular exercise. So these are general principles applicable not only to all children, but also to children who are at high risk. So in those at high risk, in addition, of course, treatment of underlying disease would be important. So if we are dealing specifically with, say, malabsorption states, then treatment of underlying condition, screening and maintenance of optimal intake calcium and vitamin D status, endocrinopathies, initiation, regular administration of HRT is very critical in patients who have pubertal failure due to any reason. Drug-induced, I think Meera has already spoken about, minimize exposure to the extent possible. It is not obviously very easy. In a patient who's immobilized, optimum nutrition, evidence indicates if you have a patient who's bedridden, even if that person is made to stand, even that itself is shown to improve the bone mineral density. So some little effort can surely be made to aid maintaining bone mineral density. Hemoglobinopathy is very important. We see a lot of thalassemias and we published on that also, Dr. Rajni, you would remember. So endocrine screening and timely HRT as required. And as we talk, that almost 60 to 80% of bone mass is genetically determined. So if we are in a situation where we know that osteoporosis runs in family, but that's a wonderful opportunity to identify those children and have a targeted diet and exercise planning for these people. I think that's it. Thank you.
Thank you, ma'am. So now we come to the end. I'd just like to give some take-home messages, and I'd like to thank the panelists very much for this very informative talk. So do biochemical investigations and radiology in all cases of rickets. These are the messages that we have got in this talk. And nutritional rickets, always treat with lower doses of vitamin D and give calcium also. So we should use lower doses to prevent any toxicity from occurring. Look for biochemical and radiological response after 4 to 6 weeks. If there is no response by 12 weeks or other features as have been described, think of non-nutritional causes. Supplement vitamin D in all pregnant ladies, infants, and high-risk cases. And do not do routine testing in non-high-risk cases. Osteoporosis definition and causes we have learned and how to prevent. And we should carefully interpret a DEXA scan in children and look at the Z score and whether pediatric data has been utilized to see the BMD, and the role of calcium supplementation in the recommended daily allowance, physical activity, and prevention of junk food and colas and caffeine to maintain bone health in children. So thank you very much, everyone. And now I'd like to hand over to the organizers and the audience for any questions.
Thanks a lot, Dr. Rajni, for a very informative panel. And thank you, Dr. Anju ma'am, Dr. Divya, Dr. Medha, and Dr. Amarnath for a very informative. There are lots of questions in the audience, but I will just like to take a single question. I think that's quite relevant to the present era. Should homebound children in COVID times, mostly sedentary, be supplemented of vitamin D? If somebody can...
It's like this. Let me answer that. We had a panel on that. There is evidence, some evidence that people who are low in vitamin D may have a worse clinical course of COVID. It doesn't really make them more vulnerable to COVID, but may have a worse clinical course. But the evidence is also that it is not only vitamin D. The evidence is also for other vitamins and minerals and vitamins. So it's very interesting that what you need is, again, we go back to a healthy diet. So I don't think, it doesn't make sense that they're sitting in front of a couch, they're eating potato wafers all the time, they're gaining weight, but they're taking vitamin D and they think this is a malady, this is the answer to all their maladies. So I would suggest please focus on a balanced diet which contains adequate amount of vitamin D as well as other vitamins and minerals. And
I think the person wants to ask that as they are homebound, they are not exposed to sunlight. Should that be a reason?
Nobody is homebound anymore,
Yeah,
and
I think that is the best way of treatment. Expose more to the sunlight.
Yeah.
Thank you.
There are lots of more questions, but I think there's a time doesn't allow me. So I will just request the panelists, if they have time, they can please answer them in the question and answer sessions. And I thank you all. And with this, we will wind up this session. And thanks a lot. And we move on to our next session. For the next session, we have a very interesting session on approach to obesity by Dr. Anurag. And for this session, I would like to invite Dr. Sandeep Jain. He's a consultant at Rajiv Gandhi Cancer Institute. He's a pediatric hematologist. And I like to invite Dr. Shekhar, who is a consultant at Jaipur Golden Hospital. So I will please, Dr. Sandeep, please introduce Dr. Anurag for the next talk. Over to Dr. Sandeep.
Thank you, Richa, and thank you, North Delhi for the interesting webinar and for the kind invitation. I hope you can hear me. Can you hear me?
It's a very
low
volume is less.
Can you hear me now?
Yeah. Now.
Hello. Can you hear me?
I think it's not very clear.
My voice is not clear?
Intermittently, it's get clear. Intermittently, it's not.
Okay. Thank you, Richa, and thank you, North Delhi IAP, for kind invitation. And the next topic in this webinar is approach to a child with obesity. I think it is a very pertinent topic, and as we were discussing some time back, the children are now homebound and they're not going to school, and therefore this is a more of a challenge in this scenario. And for the discussion of this very pertinent topic, we today have very renowned pediatrician and endocrinologist, Dr. Anurag Bajpayee. He is consultant pediatric and adolescent endocrinologist at Regency Hospital, Kanpur and FMRI, Gurgaon. He has done his MD from AIMS and also fellowship from Royal College, Australia, physician from Australia. And he has like many publications in the national and international journals and has more than 200 presentations in the state, national and international conferences. Welcome, Dr. Anurag, and over to you for the talk.
Okay. Thanks a lot, Dr. Sandeep, for the introduction, and thanks, Dr. Richa, again for first of all, congratulations for this wonderful program and bringing all of us together. Obesity is clearly one area which has been of quite significance, and unfortunately, what is happening is that there seems to be a confusion in terms of different forms of obesity. So I had a 16-year-old boy with obesity who presented to a pediatrician with a weight of 127 kgs. Massively obese, and you can see a lot of acanthosis nigricans there, very clearly BMI of 46. And what happened was that the TSH was found to be 7.5 and started on thyroxine. Now, if we really assume that this level of obesity is just because of this TSH of 7.5, that is what a big confusion happens. And 1 year later, he presented to us with frank diabetes, non-alcoholic steatohepatitis, and all those problems. So this is one situation where we are labeling somebody as a cause of obesity as hypothyroidism or a clinical cause, wherein we don't, we haven't done the evaluation, and that's what happened later as to in terms of complications. Now, the second situation was again a 12-year-old girl with obesity, the other way around, who basically presented with obesity and growth failure. And this will be a recurring theme of my presentation about how growth becomes absolutely important to evaluate in that perspective. Screening tests were normal, advised lifestyle measures, presented 2 years later with a rapid weight gain, and she had all the features of Cushing syndrome. So while we're talking about obesity, it is a very important balance to understand between pathology and physiology. Now, obesity is increasing very significantly. This is our data from Kanpur, which over 5,000 children show that there is a dramatic increase in obesity, particularly across girls beyond 13 years, where the prevalence may go up to around 30%, and it causes complications like hypertension and all. So if we go by the ballpark figure of 10 to 15% of obesity, most of them are physiological. So 95 to 98% will not have a pathology, and it will only be those 2% will have a pathology. The main aim of the treating pediatrician is to differentiate these physiological forms from the disorders, case 1 from case 2, so that no unnecessary workup is done and an appropriate management happens. And that's what I'm going to do over the next 15 to 20 minutes or so in terms of how to approach, evaluate, and manage in that perspective. So now you can all go and have a look at our website, learning.growsociety.in, which provides a lot of these presentations which are already there in the video recorded format. You can have a look at our courses available and our application, which will help out in that perspective. Now, when we talk about obesity, it can basically be classified into physiological obesity, which is, as I said, 98%, characterized by normal growth, normal puberty, and normal development. So if you have everything normal, don't do unnecessary workup from that perspective. When we talk about pathological obesity, it may be genetic or syndromic, which may be monogenic. Now, this monogenic obesity is rare, but it is more likely if the onset is within 5 years or within 2 years of age with hyperphagia. So if you have that group of population, you have to evaluate for genetic causes. The most common cause here is the MC4 receptor defect. And now we have got leptin receptor, and now next genome sequencing is available, but do it only if it is less than 2 or 5 years of age, morbid obesity, severe hyperphagia. There could be syndromic causes, which will be evident via clinical picture, dysmorphism, facial abnormalities, digital abnormalities, difficulty in vision. Will give you the diagnosis in that setting. So there will be hyperphagia, visual and pubertal abnormalities. Secondary causes could be hypothalamic. So if you have a child who had a CNS insult, has a headache, seizures, think of a rapid onset hypothalamic obesity, and of course drugs. The most important drugs that you need to be bothered about are valproate, because that's very commonly associated with weight gain with the treatment of anti-epileptic drugs, as well as, of course, steroids and lot of these SSRIs which tend to cause a rapid weight gain in that perspective. So again, you will have hyperphagia in that setting. Endocrine causes are rare causes of obesity, but they are important to identify because they are treatable. Think of hypothyroidism, Turner's, growth hormone deficiency, pseudohypoparathyroidism, Cushing's. Key features will be effect on growth and puberty, and that would have a huge impact. Now, the pediatrician evaluating a child with growth failure has to answer three questions basically. One is it really obesity? If it is obesity, is it physiological or pathological? And finally, if it's pathological, what is the cause and what are the complications? So we'll use very simple way in terms of your office practice to do these tests and evaluate and manage accordingly. Now, when we talk about obesity, we are not just talking about increased weight. We are talking about increased body fat. Now, whatever we are doing is basically a surrogate marker of fat. So as we were discussing in the last session, we talked about bone density. That's a surrogate marker of bone strength. Here again, most of them are surrogate markers. So we use body mass index, waist circumference, regional adiposity, skin fold thickness. Then you have an option of gold standards like DEXA, bioimpedance, and plethysmography. So which of these would be the ideal one? And we all know that BMI is the one which is most easily available. So if you look at BMI, this is one which is clearly associated with mortality. As the BMI in the Western population goes above 25, the mortality increases. Above 30, it shoots up. In Indian population, we tend to have a greater amount of body fat as compared to the amount of BMI. So in India, we use a cutoff of 23 and 27, and many people are talking about decreasing that as well. And from that perspective, we have to use the appropriate chart. So if you're talking about BMI, the next question which comes in, which chart should we use? Should we use the CDC chart? Should we use the IOTF charts, or should we use the IAP charts? Now, these are the American data. IOTF, the International Obesity Task Force, is a multinational data tracking from 30 as obesity and 27 as 25 as overweight, and IIP 2015 is Indian data tracking from 27 and 23 in that perspective. So there are a lot of information available that if you use Indian charts, you will pick up more children with obesity. But the big question is whether that is significant or not. So this was our paper, which is just going to be published next month, which clearly shows that if we use the Indian charts, we are going to pick up more children with obesity, but more of them will have hypertension. So while we are increasing the prevalence of obesity using IAP charts, they are actually significant. So if you use the WHO or the IOTF or the CDC charts, you're missing out on obesity, which is causing complications. So this is very clear. IAP 2015 is clearly the one which we should look at in that perspective. Now, of course, body mass index has got a lot of limitations. It tends to overestimate BMI with muscularity. There are issues of puberty, and there are issues that it does not correlate very well with fat. As I said, for Indian people, there tends to be more fat as compared to the Western population for the same level of BMI. And what does it mean from a clinician's perspective? We again evaluated the various surrogate markers of obesity with fat percentage in a large population. And what we found, interestingly, was that BMI was the best predictor of body fat as against waist circumference, neck circumference, wrist circumference, or mid-arm circumference, anything you want to look at. So if you want to follow BMI, follow IAP 15. That is a very clear criteria, which is now coming out of evidences from these two big studies. Once you have shown that this child is obese, the next question is it physiological or pathological? To answer that question, basically you have to just look at three things. Look at growth, look at puberty, and look at development. If growth, puberty, and development all are normal, it is highly likely that we are dealing with a physiological cause. But if you have an obese child with short stature, consider an endocrine cause. Obese child with delayed development, think of a syndromic cause in that situation. Most important factor, of course, is growth. When we talk about somebody who presents to us with short stature, we say the most important thing to look at is actually the weight. The most important thing to look at in an obese child is actually the height. If you have a child who is obese and tall, it is usually nutritional, constitutional, exogenous, physiological, whatever form you want to say. While, and this will be the growth chart pattern you will see, they will be tall. While if you have a short and a plump child, a child who is short and obese, start thinking of an endocrine. And there when your height, age, and weightage become important parameters to differentiate these two. Now we'll go on to first case, 12-year-old boy, height is 160, weight is 70 kg. Parents are ideal height, bone age is 12 years and was found to have a slightly high TSH. Now, whether this TSH is significant or not, before we go ahead with that, we have to interpret the growth chart. So if you go by our growth interpreter and plot the chart, what we are seeing clearly is that this child has a positive height standard deviation score. So he's tall basically for the family, which and as well as the population, so it makes an endocrine cause extremely unlikely. As Dr. Eason was mentioning, this high level of TSH, as we also saw in the first case, is the effect of obesity and not the cause of obesity. So if you have an obese child with a TSH between 4.5 to 10, there is no goiter, no thyromegaly, no family history, and TPO antibodies are negative, we do not need to start treatment with thyroid, wait and watch. And this is something which is important. But there are other evidences which are coming up, and this is our recent data in which we evaluated 400 obese children with regards to their thyroid function, and we found that 34% actually had a borderline TSH between 4.5 to 10. And when we looked at whether this subclinical hypothyroidism was doing something bad to them, we observed that individuals who actually had a subclinical hypothyroidism had a significant odds of developing non-alcoholic steatohepatitis. So while these are initial evidences coming up that at the moment we don't need to treat somebody who has a subclinical hypothyroidism, we need to re-look into the whole parameter because there may be something harm which is happening. And the effect of obesity on NAFLD was actually mediated through subclinical hypothyroidism and not the other way around. So this is an interesting observation, but don't read if the TSH is 4.5 to 10 and the TPO is negative currently at the moment. Now we have another case, 12-year-old girl with a height of 130 centimeters, weight of 58 kgs. Everything was normal, screening test was normal, reassured, presented now with rapid weight gain. And this is the growth chart. So this is a classical case of a short and a plump child. And this is very clearly suggested that we are dealing with an endocrine cause, and we need to definitely evaluate for some other causes, and we can't just leave the child like that. And if we go by our growth interpreter, put the data in, again, it says an endocrine pattern because the height is affected. So a short and a plump child, very important to evaluate and turn out to be a Cushing syndrome in that situation. So if you just go by basic clinical parameters, you would be able to identify in most cases in that situation. Now, once we know that this is the basically a pathological cause, the next question is what is the cause? And the evaluation, of course, will start from history. So a detailed history about nutrition, how much calories they're taking, whether they're missing breakfast, whether they're having snacking, and all those parameters become important. Physical activity is important because in our school study, 1 hour of extra physical activity was associated with 2% reduction in body fat. So physical activity is important. Of course, mobile screen times, very importantly, history of steroid intake, risperidone, very commonly used now, can even cause type 2 diabetes, valproate. If there is infantile hypotonia, there is hyperphagia subsequently, think of Prader-Willi syndrome, and CNS features, headache, vomiting, developmental delay, temperature instability, think of a hypothalamic obesity in that situation. You have to look at pointers to diagnosis. If there are features like Cushing syndrome, if there is brachymetacarpia, think of a pseudohypoparathyroidism. Again, almond-shaped eyes. If there is a short hands and feet, there are prominent philtrum, then think of a possibility of a Prader-Willi syndrome. Extra digits, think of a Lawrence-Boone beetle. Eye abnormalities, nyctalopia, think of Lawrence-Boone beetle syndrome. And of course, if there is pubertal issue, think of a Lawrence-Boone beetle and Prader-Willi. Now, two conditions: monogenic obesity, do not do the genetic test unless the onset is ideally less than 2 years or latest by 5 years of age with severe hyperphagia. The reports we can do is MC4 receptor, leptin, and leptin receptor. While if there is endocrine processing, when you have a growth failure or pubertal delay, always do a FT4 along with TSH. If you want to do a cortisol, I will do a 8 a.m. protocol first to exclude exogenous steroid excess, and then you have ruled out, you can do a urinary free cortisol and go from there. So a comprehensive evaluation becomes extremely important in that clinical perspective. Ask for a drug history. So as I said, prednisolone, risperidone, and olanzapine, very, very common drugs now being used, particularly with psychiatric people are using these right, left, and center. Valproate, very commonly used drug in pediatric practice. Paroxetine, more of SSRI is being used. So think of using an alternate drug which will have a lesser chance of side effects. So if somebody is on valproate, think of shifting to topiramate, which is actually approved for treatment of obesity subsequently. So these parameters become important in terms of evaluation, management, and assessment from that perspective. So now going back in terms of the flow diagram approach to obesity, first of all, look at growth and puberty, because that will give you a real clue. If the growth is normal, this is usually a clear-cut case. What we're talking about is of exogenous obesity, but do a complication screening, including an oral glucose tolerance test, lipid profile, and very importantly, SGPT, because non-alcoholic fatty liver disease is emerging as a major complication these days. If the growth is compromised, think of endocrine causes, thyroid, steroid excess, calcium, phosphorus, CNS insert, think of an MRI, hyperphagia, the development is normal, think of genetic defects, while it is abnormal, think of Prader-Willi, and then you can go from other parameters. So basically look at growth, puberty, development. Most of your diagnosis will be very clear in terms of obesity in that situation. We have now a 7-year-old boy with rapid weight gain, and what we are seeing here is that weight is 42 kgs and height seems to be slightly low. There was a history of infantile hypotonia and failure to thrive. Hyperphagia is there, developmental delay is there. Pretty much our diagnosis is made. And if we go into the way we have developed the approach pathway, that will really help out very simply to put in those question answers, and what you will find that this child is not on drugs, development is abnormal, there is no neurological insult, go for PTH, and finally you will get the diagnosis of Prader-Willi syndrome in terms of these shorthands. So this is an important consideration in that setting. 1-year-old girl with rapid weight gain, very significant weight gain recently, 16 kgs, very hungry at night, always drinking. FT4 levels are normal. TSH was slightly high, started on steroids, on thyroxine with no response, normal development genitalia. A very, very interesting case. If you have a borderline TSH, as I said, this could be the effect of obesity, but one consideration at that very early stage could be a GNAS, GS alpha mutation, that is pseudo-hypoparathyroidism, in which there is TSH resistance, and this girl actually turned out to be a pseudo-hypoparathyroidism. Mother had bradycardia, mother had calcification. We were able to pick up this case. So very importantly to identify and look the entirety before you reach at a particular diagnosis. 14-month-old boy with rapid weight gain, and weight is 17, height is 80 centimeters, always feeding, just like the first child, continuously fed. She once developed vomiting, became very quickly dehydrated, admitted with hypernatremia, and this gave us a clue that this was actually a diabetes insipidus. So if somebody has diabetes insipidus, would like to drink a lot of liquids, if you give them water, they become dehydrated, failure to thrive, you give them fluid, a lot of milk, they'll become more obese. So this was a classic case of central DI presenting with obesity. So all these causes you have to consider in terms of evaluation becomes easy in that perspective. Final case, I think 3-year-old girl with rapid weight gain, height of 84 centimeters, weight is 26, severe hyperphagia. So again, if you have this early onset of weight gain and hyperphagia, you have to think of a pathology, and this turned out to be a genetic defect on MC4 receptor. So these are rarer causes. 98%, as I said, are physiological, but when there is an appropriate situation, you have to evaluate and consider these possibilities in that perspective. Final words, very importantly, about the complications. So obesity can affect every part of the body from head to toe. I would be really concerned about fatty liver. That's very, very common now. Of course, hypertension, nearly universal in obesity, type 2 diabetes, polycystic ovaries, slip capital femoral sleep apnea. All these are very important. So you have to do a proper evaluation in that perspective. Some conditions which will come to you, but they are not really pathological, include buried penis, in which penis is normal, but parents are really concerned about the penile size. You do a stretch penile length, it will be normal. If you feel that there is a rickets-like presentation, it means basically will be often because of obesity, and of course gynecomastia, which is lipomastia and not gynecomastia in the true sense. Basic workups, I would say, do a blood sugar fasting in a 2 hour. We are not very much happy with the HbA1c, so do a fasting 2 hour value. Levels more than 100 and more than 140, start thinking to worry. Don't go by adult levels, go by the concern levels. So cholesterol, if they're going high, LDL going high, triglyceride going high, think of a worry. Now, AFP, ALT, SGPT is a big debate. A lot of people are talking about figures of 20 and 15. We would think that levels more than 40 are more significant, and levels above 60 show that there is less chance of recovery over time. So we have to be very, very cautious in that perspective. And this is our data, which shows that metabolic complications are there in around 60% obese individuals. Very importantly, many of them remain healthy despite these complications, and those who have a family history of diabetes, those who have a large small for gestational age have a higher risk. So we have to be bothered in that perspective. So just to summarize in terms of the learning points, 98% cases that you're dealing with will be nutritional, they'll be rarely endocrine. Growth, puberty, and development are the key. If they're normal, think of complications. Do not treat TSH levels between 4.5 to 10. If the TPO is negative, there is no goiter, there is no family history, look for complications, particularly sugar abnormalities, lipid abnormalities, liver abnormalities, and of course, mechanical things like sleep apnea and slip capital femoral epilepsy are also becoming very common in that situation. You can all go through our website, learning.growsociety.in, to have a look on our various courses which are available and the information from there. So I think we'll close on to that topic, and if there are any questions, would be happy to take care of.
Yeah, thank you very much, sir. Am I audible?
Yes, yes, yeah.
Yeah, thank you, sir. Thank you, Anurag, sir. It was a very interesting talk. Actually, we are having so many patients these days because of this COVID era, and percentage definitely increased. So for the next, actually, sir, we don't have much time. We are running short of time, already 30 minutes delay. So if possible, please answer the queries in Q&A section. So please help us. And for the next session, I would like to invite Dr. Shekhar as a chairperson. Dr. Shekhar Vishwas is a senior consultant and a very well academician of North Delhi IAP, a core member. Doctor, over to you, Dr. Shekhar. Please introduce next speaker.
Thank you, Dr. Shalini, for inviting me. And it was a really very good eye-opener what Dr. Anurag said, and the topic was fabulously explained. Our next speaker is Miss Mansi Chaudhary. She's a dietitian from Fortis Hospital, Shalimar Bagh. She has been certified by IYCF and BPNI and certified food preparation specialist, visiting faculty, T. Chaitram Medical College and Research Center in Nutrition for undergraduate. So over to you, Ms. Mansi Chaudhary, for a special diet in obese children.
Hello everyone. Good evening. Am I audible?
Yeah, you are.
All right, okay. So here we are discussing about the meal plan. When a child has type 1 diabetes, meal planning is very important. So everything what a child eats can affect his or her blood sugar levels.
Dr. Mansi, you are not visible. Dr.
Okay,
Mansi, you are not visible.
Okay. Hello?
Yeah,
you are audible. Now you are visible.
Do you need to share some slides? Do you need to share some? Or
Ma'am, no, it's an audio.
That's perfectly fine.
Okay, so am I audible now, visible also? Okay. So good evening, everyone. Hello. When a child has type 1 diabetes, meal planning is very important. So everything what a child eats can affect his or her blood sugar levels. Kids with type 1 diabetes need a nutrient-rich food that helps them grow and maintain a healthy body weight. So here comes the ideal diet plan. So they would be taking 10 to 20% of their calories from protein, around 25 to 30% of their calories from healthy fats, and about 50 to 60% from carbs. So when we talk about carbohydrates, it should be complex carbohydrates, for example, whole grains, whole wheat, oatmeal, which will also control their blood sugar levels by providing them proper vitamins, minerals, and fibers. We should also take care that simple carbs should be avoided in the diet as it raises the blood sugar levels immediately. Amount of carbohydrate depends on their weight, age, size, and any medication they are undergoing through. So accordingly, the grammages, the serving sizes will be decided in the kids' nutrition. Carbohydrate counting, as we all do in our day-to-day practices, is very, very important. So parents can do the carb counting, which the kid is eating at every meal or at every snack. And then insulin doses will be adjusted accordingly, which will also keep the blood sugar levels steady for the kid. Now there is another idea of exchanging the meal plans. With an exchange meal plan, child's menu will include all the amount they can take from all 6 different food groups, which is protein, carbs, vitamins, minerals, and fiber. In this case, one food will be exchanged from another food group, which will be containing the same amount of calories, proteins, and fats. So focus on carbohydrate exchanges is very, very important as this will directly affect the blood sugar levels. We should also take care to keep some snacks in hand, like free snacks like cucumbers, celery, or sugar-free gelatins. They contain a few carbohydrates. Some good kid-friendly choices can be low-fat string cheeses, hard-boiled eggs, or small serving of nuts with a sugar-free drink, which will definitely help the kid to maintain their blood sugar levels. Now we talk about foods to avoid. So there is no specific food item which we will limit in our child, but adjusting insulin doses on carb counting is the one way out which can help us to control their blood sugar levels. Also, monitoring is very much required. So child's carb counting, doses of insulin intake, and their blood sugar readings. So this is the thing how we calculate in our day-to-day practices, and we try to maintain the calorie counting, and we try to maintain the blood sugar levels. So we cannot be very rigid, very strict in kids' case. We need to plan the diets accordingly, maintain their insulin levels, and do the carb counting so that every protein, vitamin, minerals, fats can be given to the kid. That's it from my side.
Yeah, thank you, Doctor. Thank you, Ms. Mansi. That was a very good information. I think we move on to the. I would like to call Dr. Akbar. He's Dr. Shalini. Are you here?
Yeah, I am here. Just a minute. Thank you, Dr. Mansi. It was a nice talk. Actually, we are going to have many questions on this, but right now I think we should move over to our next session.
Sure, ma'am.
Next session is on psychological issues, and for this I would like to invite Dr. Akbar Khan. Dr. Akbar Khan is a neonatologist and child specialist at Baby Home Children Hospital, Shamli. Over to you, Dr. Akbar Khan.
Good afternoon, everybody. And first of all, I would like to thank Team endocon and especially Dr. Richa for inviting me and making me a part of this academic meet. Thank you. Now, for the next talk in this session, which is about psychological issues in children, I would like to welcome Ms. Ayushi Khaneja. She is a counseling psychologist in Department of Pediatric Hematology Oncology, Rajiv Gandhi Cancer Institute and Research Center, Delhi. She has a work experience of more than 5 years. She did post-graduation in applied psychology from Jamia Millia Islamia and graduation in psychology from Daulat Ram College, Delhi University. She also did internships from Chacha Nehru Bal Chikitsalaya, Sir Gangaram Hospital, and Lady Hardinge Medical College. So with this, over to Ms. Ayushi Khaneja.
Thank you so much. Thank you, Dr. Akbar Khan, for a very warm welcome. I would like to take this opportunity to thank Dr. Richa specially for believing in me and giving me this opportunity, and Indian Academics of Pediatrics, North Delhi. So I hope my voice is visible. Am I
It's
audible?
audible. Yeah, it's fine.
It's fine. Okay, so just a moment and I'll start my screen share. Okay, so this is indeed a very interesting topic which I have been given to talk about, which is psychological issues in obesity. So just to start with a little background, as per the WHO global estimates in 2014, almost 50% of adults are overweight, with nearly a third of them being obese or having a basic metabolic rate of more than 30 kg per meter square. In a recent nationally representative study, an estimated 135 million people were found to be suffering from generalized obesity, and high prevalence rates were noted in both rural as well as in urban areas. These figures make it clearly that obesity is assuming epidemic proportions cutting across age, sociocultural, and ethnic boundaries, thus becoming a significant public health issue. If I talk about childhood obesity, India has 14.4 million children with obesity, and it is the home to the second highest number of obese children in the world after China. As per the UNICEF data, the global prevalence of childhood obesity has increased from 4.2% in the 1990s to 6.7% in 2010 and is further anticipated to raise to 9.1% by 2020. Similarly, in the adolescent age group of 12 to 19 years of age, obesity's prevalence has increased from 5 to 18.1%. It increases the risk of non-communicable diseases like diabetes, hypertension, and coronary artery disease at a younger age. In addition, obesity affects the child's social as well as emotional well-being and the self-esteem as well. Therefore, it's very important that while we are trying to manage a child with obesity, to look into the psychological factors as well. Depression and social withdrawal is more often seen in children with obesity. So here are few of the factors or causes which can contribute to obesity. So if I talk about the biological factors, genetics, brain gut axis, prenatal determinants, pregnancy, neuroendocrine conditions, medications, physical disability, viruses, certain viruses, they can have an impact on childhood obesity and obesity in general as well. And along with biological issues, there can be other factors also which can contribute to obesity, like lifestyle factors or your behavioral factors, which can have excessive calorie intake. Eating patterns are not that healthy, sedentary lifestyle, especially during this pandemic where we all have become so lazy to be physically active. Insufficient sleep, smoking, and at times some studies have also shown that drug abuse can also lead to obesity. Certain environmental factors like built-in environment, socioeconomic status, culture, bias and discrimination, environmental chemicals can also lead to obesity. So the cause of obesity are rarely limited to genetic factors, prolonged eating, or a sedentary lifestyle. What we do and don't do often results from how we think and feel. So many a times, I feel the psychological factors are left behind and we don't really focus on, other than the medical reasons, there could be other factors also which can lead to obesity. So unless we act to address these emotions, however, these short-term coping strategies can lead to long-term problems. So what all psychosocial issues can lead to obesity? So one of them very common is stress, anxiety, depression, binge eating disorder, low self-esteem, low educational attainment,
less social interaction or a limited group of friends, probably, body image dissatisfaction, disturbed interpersonal relationships, family dynamics, and dietary habits. So it is seen that kids who are obese, they mostly have their parents also tend to be a little obese, or the practices or the eating habits that they follow is quite unhealthy, which can lead to obesity. Lack of sleep, it's very interesting that lack of sleep, which can lead to hormonal changes, can also lead to obesity. And there's a very interesting syndrome which is called nighttime eating, wherein a lot of people have this habit of waking up at night and munching something or the other. Socioeconomic issues, like there is not a safe area for many kids, especially during this pandemic, and for other people also who are who live in a more urbanized area. They don't have a safe area to exercise, lack of knowledge about how to cook healthy food, money constraints where they don't have much choice to buy healthy food.
हेलो
And some of the psychosocial
कहाँ पर
issues
हैं बाकी सारे
uh, which can lead to obesity. So next, very interesting. Is there a link between obesity and mental health? Yes, of course. Definitely there is a link between obesity and mental health. Numerous studies have demonstrated a positive association between obesity and various mental health issues, including depression, eating disorders, anxiety, and substance abuse. Obesity impacts the individual's quality of life, with many sufferers experiencing increased stigma and discrimination because of their weight. Obesity is also frequently accompanied by depression, and the two can trigger and influence each other. Serotonin dysregulation that leads to depression may also cause increased consumption of carbohydrates to try and regulate the serotonin levels. Although women are slightly more at risk of having an unhealthy BMI than men, they are much more vulnerable to the obesity depression cycle. In one of these studies, it has been seen that obesity in women was associated with 37% increase in major depression. There is also a strong relationship between women with high BMI and more frequent thoughts of suicide. Binge eating, a behavior associated with both obesity and other conditions such as anorexia nervosa, which is also a symptom of depression. A research source shows that obese women with binge eating disorder who experienced teasing about their appearance later developed body dissatisfaction and depression. So, psychological consequences of being overweight or obese can also lead to low self-esteem and anxiety. Obese or overweight people are looked down upon, and it is very easy for them to feel bad about oneself and to become depressed and anxious, or to develop obsessions around eating control when one's culture make it clear that the one way to appear is wholly undesirable. So many a times it's considered that eating is pleasurable, and because this is true, all manner of people, fat and thin both, end up using eating as a ready source of emotional comfort when they are feeling stressed out. It comes as no surprise that such stress-induced eating leads to weight gain, which in turn leads many people, especially women, to feel still worse about themselves, motivating still more stress-based eating and additional weight gain. All too often, stress-based comfort eating becomes a vicious cycle and downward spiral. I have just missed the last slide. Some of them. So overweight people also tend to have less energy than their normal weight peers. And because it takes them more efforts than their peers to be more active, they tend to gravitate towards low activity lifestyle and become sedentary. An uncomfortable cycle develops wherein the less active people become the greater their risk of gaining still more weight, and the more weight people gain, the less likely they are to become more active. Life stresses seem more overwhelming as exercise is avoided, and a major opportunity for the reduction of muscle tension stress and anxiety is lost. Over time, even ordinary tasks of daily life, like going up a flight of stairs, can lead to exhaustion and a sense of premature aging. So as I have mentioned, approximately 5% of persons with obesity suffer from the night eating syndrome, which is an eating, sleep, and mood disorder. The most common type of anxiety disorder in people with obesity is social anxiety disorder, wherein they have this anxiety when they go into the social surroundings or social areas. It is not surprising that people with extreme obesity report increased anxiety in the social situations. Persons with extreme obesity report some form of emotional neglect during their childhood, ranging from verbal abuse, emotional neglect, or other family dysfunction associated with separation, divorce, or substance abuse. Negative thoughts and feelings about our bodies may overflow into our other areas of life as well. Therefore, it's very important to address the psychological factors while trying to have a plan for obesity management as well. So for a teenager who thinks that I'm always going to be like this, any of my efforts are going to be useless, these kind of negative thoughts can actually have an impact on their self-esteem. So we need to consider those thoughts and address them so that we can help them with obesity management. The amount of time it takes to lose weight and the natural tendency to slip up occasionally can leave people feeling discouraged and disappointed. This can lead to self-criticism, anger, or even guilt about letting friends or family down. Sometimes difficult feelings and constant worry over weight makes a person eat more. So other than the psychological concerns or the psychological issues, there could be some social concerns as well. So one of them is worry about what others think. So there is always this cognitive restructuring which is going on in the mind of people who are obese, that what other people will think about me. So when people judge you unfairly, it can make you feel like it's all your fault. Another social concern is teasing and bullying, which I feel is very common amongst those who are obese, which can make them feel sad or embarrassed. Fear of being judged or rejected might make you shy away from people. You may stop doing things you enjoy, but the best thing to do is to take your mind and other people's off your weight and back onto you as a person. Social discrimination, which is very common in school, college, workplace, weight bias, negative attitudes that affect your interaction, that that person is too lazy to lose weight, or there is lack of willpower, there is lack of motivation, and stereotypical thinking that we have about people who are obese can lead to a lot of stigmatization, rejection, prejudice, and discrimination, which can either be in verbal, physical, or relational forms. It can be subtle or even in the form of overt expressions. And then there is this ideology of blame, that a person who is obese.
Sorry to interrupt you, Ayushi. I think we are running out of time, so we just wind up.
I'll try to wind up. Yeah, sure.
Okay.
So some of the psychological interventions that we can use while having a plan for obesity management could be behavioral therapy, cognitive behavioral therapy, motivational interviewing, um, dialectical behavior therapy, compassion focused therapy, mindfulness, and of course, social support, stress management, along with yoga, meditation, and positive affirmations. So some take-home messages would be that in order to have an effective plan for obesity management, it is very important to not only look into the biological or the medical factors, but also the psychological and social factors. While treating obesity often helps decrease the feeling of depression, weight loss is never successful if the person remains burdened by the stress and the other negative thoughts or feelings. So again, the importance of addressing the psychological issues. Obesity can both be a cause as well as a result of underlying mental health condition. Avoid criticizing, stigmatizing, or discriminating against those who are suffering from obesity or who are trying to overcome this physical condition. And obesity management is always easier when the person has the support of his or her friends and family. Thank you.
Thank you.
So, without delaying, I think we should move towards the next and the last session of our endocon. Next session is on PCOS in adolescents, clinical dilemma. For this, Dr. Akbar Khan, please you take over and introduce the speaker.
Yes, for the next talk, which is about PCOS in adolescents, a clinical dilemma, I would like to welcome Dr. Bhanu Bhakri. Dr. Bhanu Bhakri is an associate professor of pediatric endocrinology at Super Specialty Pediatric Hospital and PG Teaching Institute at Noida. He did his training at PGI Chandigarh as well as endocrine training at SGPGI Lucknow. He is past Joint Secretary of Indian Society for Pediatric and Adolescent Endocrinology. He is a member of ISPAD, GPED, Growth Hormone Research Society, NNF, etc. And he's also a contributor and a part of editorial board of ESPE Portal RLC project and ISPAE newsletter. So with this, over to Dr. Bhanu Bhakri.
Yeah, thank you, Chairperson, for this introduction, and thank you, IAP, for inviting me. So I'm trying to share my screen. Is it visible?
Yeah.
Yeah. So it will be just a quick review of the issue. In fact, the issue of diagnosing PCO in adolescent age group. I will not be discussing the PCOS in general in detail, but I will be specifically focusing on the issues in adolescent, because recently there is a lot of clarity over this issue, especially in the adolescent age group. Now we have to understand that adolescents, looking at their hormonal physiology per se, their normal hormonal physiology, there are a lot of overlaps with the PCO physiology as such. So it is not unusual for any pediatric practitioner to have a patient in the form of an adolescent girl coming either with complaints of excessive acne, with uncomfortable hair growth, with obesity, irregular menstrual periods, high testosterone level, which was done for any reason, and sometimes in USG, which was done for some other reason. There are this is reported as the ovaries having multiple follicle in the necklace pattern. So these are the situations where the parents are worried and the child is in front of you, and uh, if we go by the conventional criteria which are used for adults, there is a very high likelihood that the girl will be wrongly labeled as PCOS. But what it should be done? Now we should proceed. So I will be discussing in form of two cases, and I'll try to consider all the possible issues in this concept. So consider the first case in which a 13.5 year old girl presents to you. She is a girl from Sikh family, and she is a student of class 8, complaining of irregular menstrual periods and some facial acne and excessive body hair growth for past few months, and weight gain. On inquiring further, it was evident that this girl achieved her Minaki almost 1 year ago. She is having irregular periods, variable intervals are there. Sometimes the gap between the two periods is around 55 days, and periods usually last 3 to 4 days without any excessive bleeds or discomfort. Mother too remembered to have similar irregularity during her adolescence, and mother's sister received long-term treatment of for infertility with no success. Now, with this kind of background, it is very likely that the impressions are going towards diagnosing PCO, something like that there is something wrong with the menstrual physiology, and there seems to be a family history which is going towards infertility as well. However, let's proceed. She further tells that she has developed thick coarse hair during last few years, predominantly over forearm. The hair over upper lip too are slightly darker, and there are 2 to 3 coarse hair at both ends of the lips, which she plucks whenever they are visible. She developed distressing problem of acne for last 6 months, with 2 to 3 lesions consistently being present over her face. Lesions have disappeared for last 1 month after they have started taking treatment, so it is responsive to therapy. Mother and elder sister also have coarse thick hair over leg and forearm. And Freeman-Galloway score, which was done, it was 8 to 9. So this Freeman-Galloway score is one of the clinical score which is done to grade the extent of hirsutism in girls, and in which there are 9 androgen sensitive areas are checked, and this for each of the site the score varies from 0 to 4. So the maximum score is 36, and conventionally the scores of more than 8 are considered significant. So the score which has come up around 8 to 9. So again, the impression at this stage, again, everything is going towards the diagnosis of hyperandrogenism, PCO, or with a family history as well. However, let's proceed. She is steadily gaining weight for last 3 years despite having similar meals during lunch or dinner time. She is fond of fast food and takes frequently, and recently she is starting evening walk also. Mother says that she is most fittest among all family members. So, and her BMI right now is 24 kg per square meter. So at 24 kg per square meter doesn't seem to be very bad. And further, the mother says that she is the fittest in among the family members. So looks like again the metabolic and the anthropometric parameters are not that deranged. However, let's proceed further. They came to they visited their family doctor, and he conducted few tests. Serum testosterone was 53 nanogram per deciliter per dl, and the test reported normal range as 10 to 55, and ultrasound definitely was showing more than 6 follicles in bilateral ovaries in circumferential pattern, the typical necklace pattern which is described for PCO. HbA1c was 5.9%. So again, things are going in favor of PCO, the conventional form of PCO. However, now we will assess this case on the basis of the Clinical Practice Committee guidelines, which are published in Hormone Research in Pediatrics in 2015. And in fact, this particular paper and subsequent several reports have demystified several conventional misbeliefs over, or the misconceptions over the PCOS, concept of PCOS in the adolescent age group. Going with a history once again, menarche's infancy. Okay, recommendations. The majority of adolescents establish a menstrual interval of around 20 to 45 days within the first 2 years of menstrual period, menarche, and menstrual intervals persistently shorter than 20 days or greater than 45 days in individual 2 or more years after menarche are evidence of oligoanovulation. However, in this particular child, she has attained menarche only just 1 year ago. So having intermittently having menstrual irregularity ranging up to 55 days is not actually, doesn't qualify to be called as oligoanovulation. Further, if we read, any interval of more than 90 days is to be taken significantly, even if it is happening within 1 or 2 years of attaining menarche. However, it is only 55 days in this child. Lack of onset of menses by 15 years of age or by more than 2 to 3 years of age after attaining thalarchy, regardless of chronological age, should be evaluated. So this is not the case in this child. Next, this is about the degree of hirsutism, legs and forearms, hair over upper lip, slight hair, and mother and elder sister too having this problem. Now, we have to read this. This particular slide highlights a very important concept here, that the body growth pattern are dependent upon ethnicity as well as the familial trends. Okay, so what the recommendation says, that one approach to defining hirsutism is 95th percentile for the population, which is more than 8 in premenopausal adult white and black women. However, if you see that for Mediterranean women, the score is more than 9 to 10. And similarly, however, on the opposite end, if you see the Middle Eastern women, even or like Chinese, some particular Chinese women. So even the score of more than 2 is considered significant. So 8 is not a universal cutoff to be followed. Isolated mild hirsutism should not be considered clinical evidence of hyperandrogenism in early postmenarcheal years, when it may be in a developmental phase. So the hormonal milieu is evolving during these years, and it is not uncommon to find some increase in hair growth patterns, even in androgen sensitive areas, and it should not warrant a diagnosis of PCO to be labeled. Moderate to severe hirsutism constitute clinical evidence of hyperandrogenism, and girl with acne that is persistently and poorly responsive to topical dermatological therapy should be evaluated for a possible androgen excess, but not otherwise. Next thing is,
I think the slides.
my slides are not visible.
Yeah, it's all
Are
black.
these
Yeah.
are these visible now?
No.
No, it turned
Actually,
black.
Initially they were visible, now they have disappeared.
Okay, let me check it once again.
Can stop sharing and then screen share again. Maybe that helps.
Yeah, that this is what I'm trying to do. So I have stopped sharing. Now I'm trying to share them again. Is it visible
No, it's
now?
fine.
Yeah,
Yeah, it's fine now.
Okay. So where were we when it disappeared? Because it was visible to me actually. That's why I don't know. Was that
Yeah,
we
we were
discussed?
here.
We were here. Okay.
Yeah.
So it says that mild isolated hirsutism should not be taken as a sign of hyperandrogenism in this age group, and moderate to severe hirsutism definitely requires evaluation.
Dr. Bhanu, please maximize the slide.
Sorry. Yeah. So this particular slide tells us that when we use, it is a very common thing that people many a times use consider BMI the adult cutoffs. They try to extrapolate over the kids. So as we discussed that BMI of 24 was there with this kid, but 24 we have to understand that for children it is a BMI chart we are supposed to use, and BMI of 24 for this age group already qualifies to be her as overweight. So she is already overweight. And next, if we see, yeah, the evaluation, both the hormonal as well as the ultrasound. So the recommendations say that USG evidence at this age group should not be taken as a criteria. Only a single evidence which is consistently shows one of the it is considered reasonable is ovarian volume of more than 12 ml. Otherwise, any pattern of follicle should not be, or the number of follicles should not be considered as indicative of PCO. Multifollicular pattern, which is defined by presence of large follicles, does not have any relationship with hyperandrogenism. Further, it says that any single biochemical evidence of hyperandrogenism, as indicated by single values, should not be taken. But if we have any higher value, especially in the context, clinical context of hirsutism, only then we should measure the serial values and find that if it is persistent and or if it is rising, then the child should be assessed for androgen excess condition. Single androgen, we have already covered it. Although prevalent among adolescents at risk of PCOS, yeah, insulin resistance and hyperinsulinemia, again, they should be established as a marker of metabolic derangement. But even if there are derangements present, this doesn't qualify the child to be called as PCO. This can be just a reflection of deranged anthropometric parameters and glucose metabolism. How to proceed? If nothing which we were thinking were correct, then what should we actually do? So now, a thorough medical history, physical examination, and appropriate laboratory assessment are essential to provide information necessary to exclude or other disorders. So now that we have understood that there is a lot of overlap between the normal physiology of this age group and PCO phenotype. So only if there is some outstanding clinical features with respect to the background, the familial and the ethnic background of the child, or If the symptoms are progressive, then only we should consider hyperandrogenism, evaluate the child, and specifically look for these conditions like Cushing syndrome and androgen secreting tumors, or milder form of congenital adrenal hyperplasia, thyroid dysfunction, or hyperprolactinemia. So these are to be assessed. So for that, these are the recommended testings which are required. And if androgen secreting tumors are suspected, only then pelvic and abdominal ultrasounds are recommended. So for this child, based upon clinical profile, so for classic CAH, 17 OHP, hypothyroidism, thyroid profile, prolactin levels, other androgens, and LHFSH, free testosterone. So these all are recommended. Now the question lies, is she PCOS and how to manage? First thing here is that labor is neither justified based upon the current recommendations and nor they are necessary. This paper tells us a very interesting thing for use in clinical practice is that these girls, rather than being labeled as PCOS, should be preferably called as at risk for PCO. Okay, so that they should be properly followed over the time, and if in case their physiology progresses and continues to stay like that, then they should be evaluated and labeled as PCO. Further, so what to be done for these the issues which a child has come right now to us, for cosmetic therapy for minor issues, and very important is to control the metabolic derangements and the possible hyperandrogenism which can be underlying. So the diet and exercise, weight reduction, and close follow-up is what all is required for this child. That's it. Yeah. Just a short discussion, a contrasting case, a 16-year-old girl, student of class 11, but this girl is a native of northeastern India. She is complaining of excess hair growth for past 6 months and menstrual irregularities. There are only few scattered coarse hair over chin, lip, upper lip, chest, and FG score again in this child was 9. Off and on acne lesions were there, and according to mother, females in the family have very less hair growth. She was menarchal 3 years ago here and irregular since then, interval up to 55 days. BMI is 20 and she was worked up. USG pelvis, again, it is very common to have a report showing PCO morphology. HbA1c was fine. Testosterone was mildly elevated on as per the normal range shown by the assay report. 17 OHP, however, was 2 times the upper range. And other tests were done which were normal. So how to proceed? So in contrast to the previous child, if we see that the ethnicity and the family trends wise, if we see this child is having abnormal features. So even slight the FG score of 9 in this child, if we see in the background of the familial trends, that seems outstanding. So how to proceed? So since the 17 OHP was towards higher side, ACTS stimulated tests were done, and it showed a significantly raised value. So this was a possible non-salt losing classic CH. So with these two contrasting cases, I have tried to demystify some of the concepts regarding PCO, especially in the adolescent age group. So to summarize, the important points are that PCO has a considerable overlap with normal adolescent hormonal physiology. It is important to correctly know the background in terms of ethnicity and trend of other females in family. Only outstanding and progressive symptoms need evaluation for possible condition causing androgen excess. And if such symptoms are present and if such trends are present, Cushing's, non-severe CAH, and androgen secreting tumors are to be assessed definitely. Hormonal assays to be interpreted carefully, and conventional PCO patterns on USG, they are not useful in diagnosing PCO, and assess associated metabolic derangements, and there should be a serious efforts towards diet and lifestyle.
Thank you, Dr. Banu, for a very important. Sorry. I thought you had stopped.
No, it's over.
Yeah.
Dr. Akbar.
Yeah, thank you, Dr. Bhanu. It was a very nice and detailed explanation. So over to Dr. Richa.
Thanks, Dr. Bhanu. I know it's a very complicated topic and you have dealt 2 cases and that explains a lot. So now let's move on to our last part of the, and thank you, Dr. Akbar, for joining us as a chairperson. And do remain here for the quiz session. I hope you will really like it. Now we start our quiz session. I'm sure this is going to be an interesting session. We have 6 participants that have been selected from our first round that we had on the first day of our conference. They were top 6, but the 6th person was an endocrinologist, so we have to choose in the 7th one. So we have 6 participants. I hope, Dr. Shalini, all of them are on the panel.
Yeah.
Yeah, all of them are on the panel.
Yes.
Dr. Rakesh is on the panel. I can't see him. Dr. Rakesh and Dr. Ravindra. Dr. Dinesh.
Dr. Ravindra is here.
Dr. Rakesh Kumar.
Dr. Rakesh, I can't see. Yeah. Shall I put a message in?
Yeah, put the
Rest all are
You
present.
just call him up. He may be in the participant, so I can take him in.
He's present.
So let me see.
So let me introduce the participants.
Okay, Dr. Rakesh Kumar is in the delegates, I think.
Take it as a participant, in a panelist. So I will
Yeah,
request
anybody
participants.
else?
No, I think all are there. Dr. Bhanu is there, Dr. Anurag is here, Dr. Rakesh is here, and Dr. Ravindra is here. It will be good if all the participants also switch on their video.
Switch on the video, and if we take the name, kindly say hi so that everybody can see you.
So the first participant is Dr. Anita Manoj. She is a consultant at Railway Hospital, Mumbai. Then the second is Dr. Avinash Jha. He is a second year primary DNB student. He is from Batra Hospital, Delhi. The third participant is Dr. Devan Sharma. He was a senior resident at AIMS Jodhpur. Presently, he is in Noida. Our fourth participant is Jaya Pratha. She is a postgraduate, final year postgraduate at Stanley Medical College, Chennai. Then we have fifth participant is Neha Da Rocha. She's a first year postgraduate from Goa Medical College. And the sixth participant is Ram Sundar. He's a first year pediatric resident from Madras Medical College. So we have people from all over India. That feels good. So I hope Dr. Rakesh is here on the panel. Yeah, Dr. Rakesh is here. So we have our 4 panelists. Dr. Anurag Vajpayee, everybody has listened here. I just gave a talk. He's a practicing pediatric endocrinologist at Kanpur. Then we have Dr. Rakesh. He's a senior consultant at looking after the pediatric endocrinology department at PGI Chandigarh. His special interest is diabetes, and he has lots of publications to his credit. Then we have Dr. Ravindra. He is our team member as working in Hindurao Hospital. And on fourth is Dr. Bhanu. We just had listened to his. He's a pediatric endocrinologist working at Super Speciality PG Teaching Hospital, Noida. So let me just share my presentation just a minute. So we start with the quiz. Can you see my screen? Can you see my screen, Dr. Dinesh? Is my screen visible?
Yeah.
Yes. We have 6 rounds. There will be 3 rapid fire rounds and 3 1:1 rounds. In 1:1 round, for every correct answer, you will get 10 points. For a wrong answer is 0. But if the question has 2 to 3 parts, you will be marked accordingly. Decision of the respective panelist will be final. The rapid fire will be a buzzer round. You have to type Y in the chat box. Whoever types first will be allowed to answer. For every correct answer, candidate will be given 10 points, and for every wrong, -5 will be deducted. The question will not be passed. After every round, we will announce the scores. I hope the instructions are clear.
I request all the participants to in the rapid fire, you have to give in the chat box, you have to type a Y, and you kindly check it right now by typing Y. So there should not be any confusion. Neha has done it. Devansh has done it. More people, Jayapata, Ramsundar, Avinash, and one more people, Bhagwan. Okay. Anita
So let's
Manoj.
start with our first round. The
Yeah.
first round, this is Dr. Anita. Dr. Rakesh will ask the question to Dr. Anita. Dr. Rakesh.
Yeah, Dr. Anita, I hope you are seeing clearly the clinical photograph of three SIPs who presented with hyperpigmentation of skin and gums since early childhood, and there is history of hypoglycemic seizures. So the question is, which hormone or more hormones you would like to test to confirm the symptomatic diagnosis? And what is the likely diagnosis? There are two parts to the question.
I will rule out Addison's,
Okay.
and the cortisol and androstenedione should be evaluated.
Dr. Rakesh, your discretion, how much to be marked? I know
Yeah,
her answer is 100% correct. Yeah.
answer is not 100% correct. Is that right? Yeah. So she should be marked 7.5 to my mind.
Okay. So Dr. Rupesh is the scorer. I just forgot it. And in the judge panel, if there is any controversy, we have Dr. Arun Garg. He's also on the panel.
So is it okay to discuss answer here, or we leave it
Yes,
for
sir.
the end?
Yes, sir. Yes, sir. For the benefit of attendees, we should discuss the answers.
Okay. So these are the siblings actually. I think for a MD pediatrician, it's fine if they answer Addison disease, but Addison usually is not familial. So these are three SNPs actually. So there is a condition called familial glucocorticoid deficiency. These kids are having that condition. They are SNPs actually. They are brothers and sisters. So to my mind, the actual diagnosis is familial glucocorticoid deficiency, but adrenal insufficiency is also correct for a MD pediatrician. If it was DM endocrinology, then I would have expected familial glucocorticoid deficiency as the correct option. So what is the likely diagnosis? That is it. But the test which will help us is cortisol and ACTH. ACTH is very important here. ACTH will be very high, which will be clinching the diagnosis of primary adrenal insufficiency in that case. So I think that sums up this question.
Thank you, Dr. Rakesh. We moved on to the second question. Second question will be to Dr. Avinash, and Dr. Bhanu will ask this question.
Yeah, Dr. Avinash, am I audible to you?
Yeah,
yes, sir.
Yeah. So a 4-year-old girl with the diagnosed 21 alpha hydroxylase deficiency CAH visits after 1 year of being lost to follow-up. Okay. Before that, she was well controlled, and she says the parents say that they have continued the medications which were prescribed a year ago. The growth velocity in last 6 months is 14 centimeter per year. What is the recommended next step and why? So again, two points. What is the step and why? So first option is high protein diet at the child seemed to have achieved the growth spurt. Second is assurance, next visit after 6 months. Third is assessment for possible growth hormone excess in this child. And fourth is bone age and 17 OHP level.
Sir, just a minute to interrupt. In the 1-to-1 round, you don't have to write Y. So Devansh,
Okay.
you have to speak, and the person who has been asked the question will only answer. No other
Okay.
people will. So this is a normal round. So no, please don't write anything in the chat box, please.
Sir, I will go with the assurance and next visit after 6 months.
Okay, so the answer is wrong. Scorer, please to take care. Devansh, see, one thing alarming here is that child is just 4-year-old. Okay, the normal growth velocity at 4-year-old is expected to be somewhere around maybe 6 plus minus 2 centimeter per year. A child who was lost to follow up 1 year ago and now is showing to us with 14 centimeter per year of growth velocity in last 6 months, the very likely possibility is that the child has overgrown her dose, the dose which she was on, and this rapid increase in height seems to be the effect of androgen excess, okay, or the poor control of the situation. So the recommended step is bone age and 17 UHP level to reassess the situation and prescribe accordingly.
So this has been answered by Avinash, I guess.
And this
Okay,
is
Avinash, sorry.
Avinash. So Avinash is getting 0 for this.
Okay. Okay, sir.
Third question is to Dr. Devan, and Dr. Anurag will take this question.
Yeah. So I think this is a question very commonly encountered in clinical practice. A 3-month-old girl child presented with seizures and workup showed a low calcium, 6.4 milligram per day. Phosphorus levels are high. PTH levels are also high, and creatinine is normal. So now the next step is what will be the most important investigation and why. So you have to answer both part of it. Would it be 25 hydroxyvitamin D, 125 dihydroxyvitamin D, magnesium level, or parathyroid scan?
So the next thing which we would like to do is, sir, we like to have, sir, 25 hydroxyvitamin D levels.
Why?
So because at this age, sir, this 3-month-old child presenting with seizures, this can be, sir, nutritional rickets and causing, sir, vitamin D deficiency. So this is a this can be a very classical case of vitamin D deficiency rickets.
But why would the phosphorus level be high at this stage? Phosphorus is 8.2. Usually we have discussed
because this is like in this age group, the most the common cause which can add up into the vitamin D nutritional deficiencies. So giving non-human milk like cow milk and which contains high phosphorus load.
I think you are definitely right as to which test to be done. 25 OHT is right. The reason is not completely correct, because what happens is that usually when we say you have hypocalcemia with hyperphosphatemia and high PTH, we say it is pseudo-hypoparathyroidism. That is the usual diagnosis. But vitamin D deficiency, if it is long-standing, there could also be a PTH resistance-like state. So this is a very specific question looking into why the phosphorus was high for vitamin D deficiency. Usually your phosphorus should be low. So I think definitely I would probably what around 7.5 again. So 5 for the test and 2.5 for the Y, which is partially correct in that sense.
Thank you.
Okay, sir.
Thank you, Dr. Anurag, and Dr. Rupesh, 2.7.
Yes, ma'am.
And the fourth question
How
is
much marks? How much marks?
7.5.
7.5. Okay, fine, sir.
So for the
So
next
Devan is getting 7.5. Both Anita and Devansh, both are equal.
Yeah. So next question is to Dr. Jia Pratha. Shada, the question will be asked by Dr. Ravindra.
Hi, Dr. Jaya. You must be seeing the question. Am I audible to you?
Yeah, you are audible.
Dr. Jaya, the question is which of the following is not a common feature? I repeat, which of the following is not a common feature of autoimmune polyglandular syndrome type 1? Number 1 is hypoparathyroidism. Number 2 is hypothyroidism. Number 3 is mucocutaneous candidiasis. Number 4 is thymus hypoplasia. And 5th is type 1 diabetes. Which of the following is not a common feature? Answer may be more than one. Your voice is breaking, Dr. Jaya. Sorry. Hello. Thymus hypoplasia. Any other thing apart from thymus hypoplasia?
Type 1 diabetes.
Type 1 diabetes. Okay, although type 1 diabetes do happen in the APS1, but it's not a common feature and it occurs very late, actually after 30 years. And incidence is, although incidence of APS is very, very low, and type 1 diabetes is obviously. The commonest is mucocutaneous candidiasis, and thymus hypoplasia didn't happen. And type 1 diabetes, yes, it's not a common feature. So I think give him the full marks for that.
Dr. Ravinder. So next question is to Dr. Neha, and that will be questioned by Dr. Rakesh.
Yeah, Dr. Neha, I hope she's looking at the slide. We
Yes,
get
sir.
a 9-year-old girl with complaints of poor growth and lethargy and bleeding PV for last 20 days. 20 days back. So on growth assessment, she has short stature with height of -3.3 ST scores and weight of -2 ST score. Height is affected more than weight here. T3 is 0.21, below normal range. T4 is also below normal range. These are total T3 and T4. TSH is very high. Anti-TPO antibody is positive. Because she had bleeding PV, LH, FSH, estradiol were tested. LH was pubertal, FSH was on higher side, and E2 was pubertal. So prolactin level was a bit on higher side. USG thyroid was done with suggested thyroiditis, and thyroid scan showed severely impaired trapping function of both thyroid lobes. So we know here it is hypothyroidism. Diagnosis about the syndrome is not an issue. So what is the specific diagnosis or complication of hypothyroidism which can present like this?
So this high TSH has resulted in cystic ovaries, which has resulted in bleeding PV. The syndrome is called Van Wyck-Grimbach syndrome.
Okay, so reason for PV bleeding, you would like to explain a bit more?
The polycystic ovary, it is because of peripheral precocious puberty.
So why does precocious puberty occur here? Peripheral precaution. What does happen with high TSH? What actually it does?
Um, I can't exactly.
Okay, okay. I
Yeah.
think she should be getting 7.5. So it's sort of receptor mimicry, I would say, or molecular in the sense that LH and TSH, they share the receptor. So high TSH acts on LH receptors, causing increase in estradiol and leading to excess estradiol secretion and leading to peripheral precocious puberty.
Yes, sir.
Okay. And the diagnosis specific syndrome is Van Wyck-Grumbach syndrome. There is another syndrome related with long-standing hypothyroidism in boys, particularly when there is calf muscle hypertrophy.
Yes, sir.
Yeah, can you name that?
Debris-Cocker, sir.
Cocker-Debris-Semline.
Semmelin, yes.
Yeah, that's also called KDS. Very good. So these are the two syndromes, the precocious puberty in girls called Van Wyck-Grumbach, and in boys it could be KDS or Cocker-Debris-Semline syndrome. It typically has a calf muscle hypertrophy.
Yes, sir.
In boys. I think she gets 7.5.
Okay.
Okay, sir.
Okay, good.
Okay, next move on to the last contestant. The sixth question will be asked by Dr. Bhanu to Dr. Ram Sundar.
Yeah, Dr. Ram, am I audible to you?
Yes, sir.
Okay. So we have a 10-day-old newborn with elevated TSH, which is more than 100, and FT4 levels are low. And these are the reports on confirmatory venous sample. We have performed an ultrasound and it has revealed a normally visualized thyroid gland, but there was no gland visualized on the radionuclide scan. So which of the following possibilities should not be considered as an etiology in this case and why? So the options are in front of you. So sodium iodide symporter gene mutation, perinatal exposure to excess iodine, endemic iodine deficiency, and TSH receptor defect.
I think it will be endemic iodine deficiency, sir.
Okay, and why do you think so?
Because I think the uptake will be high in case of further. In other conditions, the uptake will be reduced.
Yeah, correct. So this is a 10 pointer, it seems. First one. Yeah, you are correct. So in all other conditions, the scan will be of course visualized in the USG, but because of the poor uptake, it might not be visible on the nuclear scan. But endemic iodine deficiency, it is expected to be brightly visible. Correct. So 10 points here.
Yeah, that's great. We have finished with our
Now I
first.
request Dr. Rupesh to announce the scores at the end of the first round.
Thank you, sir. After the first round, Dr. Jaya and Dr. Ramsundar both have 10 marks each. Dr. Neha, Dr. Anita, and Dr. Devansh have 7.5 marks each, and Dr. Avinash has 0 marks. Thank you, sir.
Okay. Now let's move on to our rapid fire round. For the rapid fire round, as we have already announced, there will be 10 marks for the right answer and -5 for the wrong answer.
Minus 10. Minus 10.
Minus 10? Okay.
Minus 5 or minus, whatever you decide, whatever the panelists decide. It is still.
Actually, Dr. Richa earlier said -5.
Yeah.
Okay, we can go minus 5, but
fair.
there should not be any confusion. Okay,
Yeah,
fine.
-5 is fair. -5 should be all right.
And
Okay,
we all
fine.
should not dare to go against Dr. Richa.
Okay, fine.
10 and -5, and you have to type in the chat as already been. They have done a one round. Huh? Okay, this round will be taken up by Dr. Shalini. So Dr. Shalini is here. Can you please unmute yourself?
Yeah, I'm here.
Okay.
Audible? Well, audible or not?
Yeah, you are audible to me. I hope to all of you.
You are well audible and well visible.
Okay, thank you.
I'm just starting with the first question. In a tool displayed in picture, few beads have been labeled with colors. To identify the onset of puberty, the size of the testis should minimum correspond to which of the labeled beads?
Yeah, this is wrong.
Doctor
This is wrong.
Devansh should be given the
ये तो बहुत easy था. 4 ml है.
Please don't.
Please don't
only
say anything.
Dr.
Only.
Devansh will answer it.
Yes, sir. So what we have been reading is more than 4 mm decides the onset of puberty. But to take it as a puberty, sir, we are also taking as 8 mm size for the 8 ml size as a puberty. But for all cutoffs and or theoretical purposes, we are taking more than 4 ml as a volume of testis for the onset of puberty.
Answer one.
Why are you taking 8 ml when the cutoffs are actually 4 ml? I'm a bit intrigued. Like,
sir, just in the when we were seeing in our seminar, it was being said 8 ml we are taking as the onset of puberty, but for pre-pubertal stage it is 4 ml.
So it is 4 or 8. You
4.
just come on one. 4. It is 4. It is universally 4. So don't get confused ever. It is 4 ml.
4.
Don't necessarily give two answers to cause confusion.
4 ml, sir.
Plus 10 for him.
So
Correct.
we give him 10 points.
Yeah.
Okay. Next question. An example of receptor modulator.
Just a minute.
Okay.
Okay, now.
An example of receptor
Fine.
modulator anti-estrogen drug is. Dr. Dinesh, you are seeing the chat box now. I can't see that.
Just let me write welcome first. Okay, I think Avinash Jha has given the first Y.
Okay, Dr. Avinash.
Avinash Jha has given the first one.
Shalini.
Avinash, you please answer this question.
Shall I read the question again?
Hello.
You will read.
Hello.
Yeah, Avinash. Yeah.
Sir, tamoxifen. Hello.
Yeah, you are audible. Dr. Avinash, please speak.
Sir, tamoxifen. Hello.
Yeah, that's the correct. That's the. Dr. Shalini, you read the next question, please.
Yeah.
Just a minute. Just
Right, welcome, Dr. Dinesh
First welcome should be written so that there should not be any confusion.
Right.
And please answer immediately. If you are taking time, then it will not be taken as a valid answer.
So Avinash is getting 10 marks.
Okay, sir.
Next
We move
question.
to the next question now. Dr. Shalini, please.
Yeah. Insulin, which should be used for infusion for management of diabetes ketoacidosis?
Devansh.
Dr. Devansh, yes. Dr. Devansh, please answer, please reply.
Regular insulin.
Okay, that's the correct answer. We give 10 points to Dr. Devansh. Next question.
Dr. Dinesh, please write. Okay.
Just a minute, just a minute.
Shall I move on to the next question?
Yes.
No.
Even before, you could have welcome again because there is already a Y there.
Why? Yeah, already a Y.
Now you can put the question.
Should I start, Dr. Shalini? Are you ready?
Yeah, I'm ready.
Start.
Effect of hypothyroidism on bone age. 1, advanced. 2, delayed. 3, no effect.
Devansh. I think it's Devansh.
Yeah, that's the correct answer. He said delayed, na? Yeah, that's the correct answer. Shall I move on to the next one?
No, Dr.
No,
Dinesh,
no.
right.
Hold on, be a bit slow. Yeah.
Yeah, okay.
Dr. Richa, either you write welcome or I write welcome. Before writing welcome, don't
You right, because I am sharing the screen now, so chat is not very.
So first confirm that I have written a welcome, then only after that.
Okay, sure. Shall I move now?
Yeah. GnRH analogs are useful for only peripheral precocious puberty. True or false? Dr. Devansh.
It is true.
The wrong answer. It's the wrong answer. It's -5. So the scorer to please note.
Okay, ma'am.
Actually, please, all the participants, I think Devansh is very happily writing Y even without reading the questions. So please don't do that.
I think
Please
what we
don't
need
do
to
that.
consider is that there should be a minus marking from the next round maybe.
Right.
Because if you write Y, you're getting only -5. If you get the right, it is +10. So it is blocking everybody. People are not thinking in terms of putting their option. It will make more sense to have -10.
We can go for -10. Shall we go for
No,
-10?
no, from the next round we will go for -10. Right now, the round is already in between.
That's fine. That's
yes.
Okay.
Neha, again you are writing Y. Please don't write before the question is put on.
Dr.
So either
Dinesh,
your-
please write
The
either
well.
question doesn't get passed.
So either
No,
the net is
question doesn't
either
get
Neha's
passed.
net is too slow or she's too fast, isn't it?
So Neha, if the next question is not displayed, you will get -5, and if you write Y.
Shall I move on to the next one?
Yes.
Yeah.
Perryman Galway scoring is used for scoring in which condition? Dr. Ram Sundar.
It is used to score hirsutism.
That's the correct answer. That's the correct answer. +10.
Okay, ma'am.
He should say thank you to Dr. Bhanu because he just taught that all this, making the question open.
Dr. Dinesh, yes.
Shall I go for the next one?
Yeah.
Yes.
Okay.
Apart from pancreas and pituitary, the common gland affected in MEN1 is Avinash.
No. Jaya. First.
Okay.
I am the one, sir.
Yeah, Jaya.
No, Jaya is the first.
Jaya is the first one.
That's the correct answer. Parathyroid gland. She gets 10 points for that.
Okay, ma'am.
Okay. Shall I move?
No.
Just a minute, Dr. Shani.
I'm just asking.
Okay, now you can move.
21 alpha hydroxylase deficiency. CA is inherited as autosomal dominant, autosomal recessive, X-linked dominant, X-linked recessive.
Jaya is the first one.
Autosomal recessive.
That's the correct answer. Gets 10
Jaya is
points.
given. Jay is giving the correct answer.
Sir, first, sir, it is showing me first in the chat box.
No, it is Jaya.
Just a minute.
If you see clearly, Dr. Dinesh Mittal has written welcome. After that, Jaya. After that, Avinash. After that, Devansh. After that, Neha. In this order. Jaya is the first one to write. Why? You can see in chat box.
Shall move on. Next
Yeah,
question.
no more.
Yeah.
Dagludec is a new rapid-acting insulin. True or false?
Yeah.
Devansh is the first one.
Sir, it is yes.
False.
It is,
Just
it
a
is a
minute.
rapid
Devansh,
and long.
you give your answer. Devansh. True.
Sir,
True.
it is yes, sir.
-5.
I can't hear you actually. What did he say?
He
It's a
said
wrong
true.
He
It
said
is
true.
true. So true is wrong. Yeah.
The wrong answer. Wrong answer. He gets -5.
Minus 10 now because you decided 10.
Round is
No,
one.
sir. After this
Okay.
round.
Okay.
Dr. Dinesh, let me know when to stop.
Just a minute. Just a minute.
Digulidec is not a new rapid-acting insulin. I think yesterday only Dr. Anurag and we all have discussed very clearly. It's a rather very long-acting insulin, and action persists for more than 40 hours. Dr. Anurag.
48 hours.
42 hours, more than 42 hours. So it's not a rapid-acting.
Shall I go on to the next one, Dr. Dinesh?
Yeah. Yeah.
Okay.
Fill in the blanks. Girls with Turner syndrome usually have in dash intelligence normal, below average, or above average.
Neha, Dr. Neha, I think.
Below average.
That's the wrong. They have normal.
Below average.
That's the wrong answer. That's the -5, Dr. Neha.
Turners, they are having the normal IQ. They may have some mathematically calculations problem. Otherwise, IQ is normal.
Okay, with this, we come to the end of our second round, and Dr. Rupesh for the second round.
After second round, Dr. Jaya Prasad with 30 points on number 1. Dr. Devansh on 27.5 points on second number. Dr. Ram Sundar on third place with 20 points. Dr. Avinash with 10 points. Fourth place, Dr. Neha, 2.5 points. And Dr. Anita, 7.5 points.
So congratulations,
Dr.
Ms. Jaya Pratap and Devansh. They're neck to neck, but still we don't know. Just one round makes a lot of difference. So even Neha or anybody else can go on a top. So definitely there will be a changeover till the last rounds. That is the beauty of this rapid fire round.
Okay. Now let's
Okay,
move
I think
to the third round. That is again a 1:1 round, and I will just pinpoint tell which panelist will ask me which question. So this is third round. So the first question will be asked to Dr. Anita, and Dr. Rakesh will ask this question.
Okay. So Dr. Anita can see the clinical pictures. She is a 4-year-old girl. You can see her height. It's around 72 centimeters, normal for a 1-year-old. And her height is 7.7 SD below the mean and weight is 5.88 SD below the mean. She came with already done growth hormone test, random growth hormone level of 64 nanogram per ml. So this is the facial features which you can see. There are some other features as well of the condition which are apparent. So question 1 is what is the diagnosis, and question 2, what clinches the diagnosis here? Why you say it, that the condition?
Growth hormone receptor
Okay.
or panhypopituitarism because there is midfacial hypoplasia.
Mhm.
Or Laron's disease.
So what is the answer to the first question? What is your diagnosis?
Growth hormone insensitivity, because the levels are normal, although this is not a stimulated, but still it is not acting. So it could be growth hormone deficiency or some defect in the IGF pathway.
So speaking more means then you are confusing the picture. So growth hormone resistance, you said. And what is that syndrome called?
Laron's hypothesis, Laron's syndrome.
Okay. Why you are saying so?
So because the basal growth hormone level is normal.
All right. Okay. So I think we will give her full marks. Yeah. So it is growth hormone resistance, problem with the growth hormone receptors, peripheral receptors. So this condition is called Laren's dwarfism, Laren's syndrome, named after Dr. Z. Laron, Israeli endocrinologist. Uh, this these condition will have typical features of growth hormone deficiency as such. All growth hormone deficiency will have these features, which are obvious here: very severe short stature, early in the childhood. If you can appreciate the facial features, mid-facial hypoplasia, uh, then we call it as cherubic facies or infantile facies. They are very chubby. That facial fat goes off after 1 to 2 years, usually does not regress in them. So they look chubby even at older age. And then we can see some abdominal fat here. If you can appreciate, this is a part of growth hormone deficiency or resistance as such. So similar features would be there in severe growth hormone deficiency as well. But it's resistance here because of this level which is there. All right. Yeah, I think she should get.
Very high. It is not normal. It is very high.
Very, very.
Anita gets 10 points for this. On to the next one. Next question will be to Dr. Avinash, and Dr. Bhanu will be taking this question.
Yeah, Avinash, am I audible to you?
Yes, sir. Yes.
Okay. So you have an 11.5-year-old prepubertal girl, and they have come to you for poor growth for for last 5 years. The growth trend of the child is depicted in the figure. We'll just show you. And the yellow dot indicates the current bone age, which is 8.5 years at the chronological age of 11.5 years. What is true about the clinical impression? First, you see the growth chart. Dr. Richa, the next slide, please. Yeah. So this is not a line. This is a slightly thicker, but you can at least see the trends that this was the earlier reading. This is the present reading right now, and this is where the bone age is right now. So have you seen it? Should we go back to the questions?
Yes, sir.
Okay, the previous slide. Now, listen to the options carefully. So, what is the clinical impression? Child is growing well as the current height is above more than fifth centile. Second option is should be evaluated for possible endocrine cause for growth faltering. Third is that should be prescribed vitamin D to address to the bone age delay. And fourth is that no intervention required if the current height corresponds to the mid-parental height.
Sir, I will go with the no intervention required if current height responds to the mid-parental height, as it can be some constitutional delay or like that. And there was poor growth for the last 5 years, but presently she is well.
Dr. Richa, go back to the next slide, please. Next slide. Next slide.
I think Dr. Bhanu, even we can do that slide up and down. There is an option lower available.
Is it? Okay.
Yeah.
That's a new thing. Okay. So Avinash, look at this. See, there are two important things here. First thing is that the child seemed to have dipped down the centile lines. Okay. Earlier, the child was going between 75th to 50th to 75th centile, but now the child has dipped to the lower centiles. So this is between 10th to 25th. That is point number one. And point number two is there is a significant bone age delay. Normally, constitutional delay causes bone age delay, but this degree of delay should, in presence of dipping of centiles, irrespective of whether the child is following the mid-parental height centiles, the preferred thing is that he should be evaluated right now. He should be evaluated for endocrine cause. So I regret again no mark at this point.
Let's move to the next participant. Next participant is Dr. Devansh, and Dr. Anurag will be taking this question.
Yeah, so this Dr. Devansh is an interesting case. 21-day-old child presented with prolonged jaundice. Investigation showed that he had a high TSH of 44 with a low free T4. So this looks like a primary hypothyroidism. He was born at 32 weeks of gestation and required a hospital stay for 7 days for asphyxia. During stay, he received fluids, antibiotics, vasopressors. Screening at day 3 showed a TSH which was normal. So what do you think is the cause that this TSH, which was normal on screening, is now actually causing a high TSH? Do you think this was, why was this TSH missed at that point in time? Was it because of prematurity? What is because of vasopressors, antibiotics, birth asphyxia? Which will be the most likely? Now I am asking most likely in that setting. There may be more answers than one, but will be the most likely in that setting and why?
So vasopressors can be, I think vasopressors are the most likely cause, because vasopressors are.
Which one in particular?
Sir, what I remember is adrenaline. I am not very sure, sir.
Okay, I'll give you the marks because dopamine would be the major factor, because dopamine does suppress the TSH secretion. But I think at your level, we will accept vasopressors as the correct answer. It suppresses TSH secretion. Prematurity, of course, can contribute. Non-thyroid illness can contribute. But vasopressors was very clearly given in that. So I think we'll give the full marks in this.
So we gets 10 points. Okay, that's great. So next is the Dr. Jaya Pratha, and Dr. Ravindra will be taking this question.
Yeah, Dr. Jaya, see the very carefully the clinical picture of this baby who is having microcephaly, developmental delay, proximal thrombus syndactyly of second and third, which is very visible in the picture. There are some cardiac anomaly, underdeveloped male genitalia, as you can see in the picture. Cholesterol is low. So you have three parts of your question. What is the diagnosis? How is it inherited? And where is the defect? Look very carefully, and there are a couple of very important observation already has been written. Microcephaly with developmental delay, with syndactyly of second and third toes, along with the cardiac anomaly, and underdeveloped genitalia. With one hyposphagia is probably also visible in the picture.
Don't know, sir.
Jaya, probably your signal is poor, your voice is breaking. Dr. Jaya Pratha? Dr. Jaya Pratha?
Cholesterol is low. Serum cholesterol is also low.
Low. Cholesterol is low. It has been written very separately, that is why, so that it should be very evident. Dr. Jaya, are you there?
Yes, sir.
Yeah. Dr. Jaya?
I don't know, sir.
You don't know? Okay. Anyway, we take up her answer. Dr. Jaya, yes, it's a relatively difficult question. It's a case of Emmett Smith family Optis syndrome, if you see, and it is being suspected when patient is having all these features along with the low cholesterol. It is inherited as a ARU usually we see with microcephaly and developmental delay, and these syndactyly of second and third dose is a marker along with the low cholesterol, and there is a deficiency of 17-dihydroxycholesterol enzyme. Because of that, it's a high level of that 17-DHC, and cholesterol is low. I think accordingly, there is no marks for this.
She gets no marks for this. So next is Dr. Neha, and the question will be taken up by Dr. Anurag.
The screen is not visible. Yeah.
Visible. Visible. The screen is visible.
Okay, I'll see if there's a setting issue.
Shall I read the question for you, sir?
Just one second. Yeah, now I can see. A 7-year-old boy was referred for the TSH level of 21. Workup showed a FT4 which was normal. Repeat TSH on day 14 and 21 stayed at 15 and 7.2. What are the best approach at this point of time? Would you like to start thyroxine, repeat TSH after 14 days, do a thyroid scan, or reassure? So we have now a day 21-old child with a TSH of 7.2, normal FT4. There is a declining trend, but the TSH is 7.2. What would you like to do in that setting?
So repeat TSH after 14 days.
Repeat TSH after 14 days. Okay, so we would not give you the answer on that, because if it is persisting beyond 21 days, we have to start thinking of a possible causes, especially look for thyroid scan to rule out something like a mild defect like hemiagenesis. So I wouldn't give the answer to that. Sorry for that. Yeah. The correct option would be thyroid scan.
Dr. Rupesh to see.
I think, Dr. Neha, you have not attended today's seminar. Dr. Vijay has very beautifully described all these things at 2:30 p.m. Probably you were not there. But all these things would have been very clear to you.
So for the next one, Dr. Ram Sundar and Dr. Ravindra will take the question.
Okay, Dr. Ram, as you see on your screen board, it's a 15-year-old girl referred for evaluation of short stature and delayed puberty. Examination height is 138 centimeter, which is obviously very short for a 15-year-old girl, and weight of 32 kg with stage 1 breast and stage 4 pubic hair development. Means adenarche is there. She has shield chest with brachymetacarpia and hyperconvex nails. Investigation showed FSH level of 54 million per liter and karyotyping of 45x O oblique 46XX. Now, you must be very clear what is this case, but gene abnormality, this case is presenting with a short stature. Now, this sort of gene abnormality noticed in this girl causes tall stature in which other condition? Means, as we see in this case, this is the case of Turner syndrome, which is having one chromosome is lacking. So if there is that same type of chromosomal abnormality, which is, you can say, much more 46XXX like that, or 45XXX. Marfan syndrome, Sotos syndrome, Klinefelter for homocystinemia.
Ram? Yes, sir. I think
short stature versus tall stature.
I think it is homocystinemia, sir.
Okay, so your answer is homocystinemia, which
Yes,
is wrong. Which is wrong. Homocystinemia doesn't give tall stature. It is the Klinefelter syndrome. If you see that there is one extra chromosome, and that is Klinefelter with the delayed puberty and all this.
Okay, sir.
So no marks for that.
Then we come to the end of the last second round, and Dr. Rupesh, so please announce the scores.
After the third round, Dr. Devans is leading with 37.5 points. Dr. Jaya have 30 points on second place. Dr. Anita, Dr. Avinash has third place, 20 points. Dr. Anita at fourth position, and Dr. Ramsundar at fifth place with 20 points. Dr. Neha at sixth place with 2.5 points. Thank you, ma'am.
There are certain changes in this condition. Now it is -10 and +10. So any wrong answer will give -10. Be very much clear about it. And other thing is that unless until we write welcome, don't write Y for the next round. Please, if you write Y before asking a question, we will give -10.
Okay.
Now
So
you can proceed, Dr. Richa.
We start the fourth round.
Yeah.
I will, Dr. Shalini will be seeing it. It's basically a picture round, so you have to be. So shall I start with the first question, Dr. Dinesh?
Yes, yes. Welcome is already written there. I think all panelists can see it out there.
Yes,
and,
yes.
Yeah.
What is the
now.
Sorry, Dr. Shalini, please.
No, it's
Devansh.
okay.
It's Devansh.
Dr. Devansh, please answer.
Hypothyroidism.
That's +10. Okay. +10 to Dr. Devansh.
Okay.
Shall I move on the second?
Yes. Yes, Dr. Richa. Identify.
Avinash. Avinash Jha. It's Avinash Jha. Speak Avinash Jha fast. Rapid fire question.
Orchidometer.
Correct.
Orchidometer.
+10. Dr. Rupesh, +10.
Okay, ma'am.
Next question, Dr. Richa. Identify the disorder.
Ram Sundar. Dr. Ram Sundar.
Dr.
Turner
Ram?
syndrome.
And
Sorry, I couldn't hear. What did he say?
Dr. Ram Sundar, please speak loudly.
You have to speak
Lawrence, it is Lawrence Beadle. Hello.
That's the wrong answer. That's the wrong answer.
Wrong answer.
The wrong answer.
So
Okay,
I
Richa,
request
please,
the panelists to correct
please
it.
tell them the right answer also. Have you not seen the great toe and the distance between the great toe and the first finger?
This
Dr.
is
Richa, please answer.
This is pseudo hypoparathyroidism. Shall I move on to the next one?
Yeah, next question, please.
Okay.
Identify the disorder.
Dr. Ram.
Dr. Ram
This is
Sundar, you are
this
writing.
is Lawrence Beadle. This is Lawrence Beadle.
This is yeah, that's the correct answer.
Answer is given by
Dr. Ram. Dr. Ram.
I think it was the question of pre-test also.
It was in the pre-test also. Yeah. Shall I move on to the next one?
No, Dr.
Yeah,
Dinesh is writing
Now
welcome.
you
Yes.
can move. Yes.
Okay, I'm moving now.
What is the diagnosis?
Devansh.
Devansh.
This is Turner's.
Correct. That's the correct answer. 10 points to Dr. Devansh.
Okay.
Next question, please, Dr. Richa.
Okay.
Spot diagnosis.
I think
Devansh.
Dr. Devansh.
This is rickets, cupping and playing in rickets.
I think Dr. Devansh's computer is working very fast in comparison to Dr. Ram. Also.
So 10 points to Dr. Devansh.
Apart from his brain, his computer is also working.
Next question, Dr. Richa.
Okay.
Common endocrine disorder associated with the condition.
Dr. Ram Sundar.
Hypothyroidism.
That's
why you are saying Dr. Ram? Yes. Dr. Ram, why you are saying this hypothyroidism?
It is Down syndrome.
So 10 points to Dr. Ram.
Next question, please.
Okay.
One test to confirm if the cause of condition is iatrogenic.
Ram Sundar.
Dr. Ram.
24-hour urine cortisol.
Dr. Richa, answer please.
That's not the correct answer.
How you will collect 24-hour urine in this small baby?
Basically, this was discussed in the spotters also. It's an 8 a.m. cortisol. And I think today Dr. Anurag also discussed the same point.
Yes,
Okay.
and I think in workshop also we discussed this.
Yeah.
We were having a same iatrogenic case.
Shall I move on to the next one?
So it is minus 10.
Yeah, it's minus 10.
Dr. Dinesh, please write welcome.
Yeah, it is there.
Shall I move?
Yes.
Yeah.
Diagnose the condition. Dr. Ram.
Thyrotoxicosis.
That's the correct answer. That's hyperthyroid.
Protruding eyes.
Points for this. Shall I move on the next?
Yes.
It's easy.
Identify.
दिवांश का कंप्यूटर चल गया.
This is in fact
Simplest question.
So we come to the end. So let's have the scores, please, Dr. Rupesh.
Just a second, ma'am.
Yeah.
Meanwhile, scores are being calculated. I would suggest for the next round, we should change the order of the participants. The questions being put to the participants, we should change the order.
Hey,
otherwise, what is happening? I am asking to the same participant every time. Similarly, everyone.
Fine, sir. We can start from the reverse order. Ram can answer.
Start from the reverse.
Ram, Neha, Jayaprata, Devansh, and Avinash, and Anita.
Okay, I will do that.
After this round, Dr. Devans is leading with 77.5 points. On second place, there are three contestants, Dr. Jaya, Dr. Avinash, and Dr. Ram Sundar with 30 points each. At third place, Dr. Anita has 17.5 points and Dr. Neha with 2.5 points. At last place.
So I think the next question should be to the Dr. Ram, and Dr. Richa, we can start the next.
Yeah, sure. So let's start with the next round, round 5. So first question will be to Dr. Ram Sundar. Dr. Rakesh will be taking that question. Dr. Rakesh, can you?
Yeah, I was muted. All right. So, Dr. Ram, which of the following criteria qualify for defining short stature in children? There are 5 options. Height velocity less than 25th centile for age, sex, and population. Height of the child more than 1 SD below the mid-parental target height. Height of the child at minus 1.8 SD score. Height of the child increased by 4 centimeters in last 6 months. And height of the child at 0 SD and mid-parental target height at plus 0.9 SD. There could be multiple options for this. Which of the following criteria qualify for short stature in children?
Sir, I would go with option 2 and 4.
Okay.
Height of the child falling 1 standard deviation below the mid-parental target height centile, and height not increase. Height increased just by 4 centimeter in 6 months period of observation.
Okay. You would like to, anyway, all right, that's fine. So he has one option correct. So first option has to be correct. Height velocity less than 25th centile for age, sex, and population. And that is a criteria. So actually the correct answers would be option 1 and 2. So he has answered second. So I think he should be scored 5.
Okay, sir.
So he gets, Dr. Ram gets 5 points at the end of this round. So next question will be to Dr. Neha, and Dr. Ravindra will respond the question.
So, Dr. Neha, what options are true regarding diagnosis of diabetes in children? Number one is type 2 diabetes does not occur in children. Number one. Number two is a random value of blood sugar more than 200 milligram per deciliter with osmotic symptom is sufficient to diagnose diabetes in children. Number three, HbA1c, which is more than 7.5%, is required to diagnose diabetes in children. Number four, at least 2 OGTTs are required to confirm diagnosis of diabetes in the asymptomatic child with incidental finding of fasting sugar more than 125 milligram per deciliter. And fifth is presence of leakage must to diagnose type 1 diabetes in children. So out of these, how many options are true? 1 or 2 or whatever you.
So the second option is true.
Second option is true. A random value of blood sugar more than 200 milligram per deciliter with osmotic symptoms. Okay. Apart from this,
So required to confirm the diagnosis findings. So 4, option number 4.
sure. So you want, what is your answer? Please.
So no, my answer only number 2. Only number 2 is correct.
Only number 2 is correct.
Yes, sir.
Yes, that is true. That number 2 is a CDC, ADA guideline. Yes, it is if more than 200 with osmotic symptoms. But apart from that, if you are having a patient who is having incidental finding of fasting sugar more than 125 milligram per deciliter, and he's asymptomatic or having no other problem as such, then probably it's not OGT, it is a single, but rather 2 would be better qualify this patient to have diabetes. I think I would like to have opinion because answer has been given by me, Dr. Richard, Dr. Anurag, and Rakesh.
I think we can give full marks because this would be a the most specific one is the second one option as per if you go by the guidelines. This one will be if all guidelines will not say that. So if you go by WHO, it won't repeat it. So ADA doesn't say to repeat. So I think we can give it's more like a practice point rather than an actual.
So we'll give full marks to Dr. Neha.
Scoring may be all right. Sorry. I would like to add. Scoring may be all right, 10 marks, but yeah, this fourth option is in the ISPAD guidelines.
ISPAD guidelines.
Pediatricians. That's all right. Okay.
As per the ISPAD guidelines, when we find this, so at least 2 OGTT, they say would be more logical to do. Anyway, we'll give full 10 marks to Dr. Neha.
So next question will be to Dr. Jaya Pratha, and Dr. Banu will take that question.
Yeah, Dr. Jaya, am I audible to you?
Yes, sir.
Okay. So this question seems to have been slightly modified, Dr. Richa. But anyway, I will try to keep it simple. So according to International Diabetes Federation criteria, which of the following are components of metabolic syndrome along with evidence of abdominal obesity in form of waist circumference? So I have already ticked one. And further, I say that there are 4 more components out of which at least 2 should be present. So waist circumference is already there. So out of rest of 6, you have to identify 4 which are identified as component. So it's all or none question. Either 4 have to be correct or maybe we can get 2.5 for each component, correct component.
Blood pressure.
1.
Triglycerides level.
2.
Fasting blood glucose.
3.
HDL levels.
4. So 10 plus. Yeah, all correct. Hope the candidates are not like Googling just in the middle of the questions. 10 plus. Yeah.
So that's right. She gets 10 points. Dr. Jaya gets 10 points. Dr. Rupesh. So next question will be to Dr. Devansh, and that will be taken up by Dr. Anurag.
Yeah, Devansh. So this is a 16-year-old girl referred for primary amenorrhea. She has a height of 162 centimeter, which is appropriate for her family. Weight is 54, which is this is a normal BMI. She has breast stage 4 and pubic hair stage 4. So breast and pubic hair are well developed. She has primary amenorrhea. Which test? So you did one test, and which really gave you the diagnosis. Was it the karyotype? What is the MRI hypothalamic pituitary region, the pelvic imaging, or the TTG level? Which test will give you the diagnosis? Single test, which will give you the diagnosis. Dr. Devansh? It's a bit difficult to Google also.
This must be pelvic imaging.
Pelvic imaging. What are you thinking of here?
Sir, I am thinking of, sir, tract malformation.
Okay. I think that's a very good answer because you have a normal breast development, normal pubic hair development that makes androgen insensitivity unlikely, so karyotype will be less likely. You have a normal breast development which makes hypogonadotropic hypogonadism unlikely, so MRI goes off. Celiac, usually you will not have that much breast development, your weight and height will be compromised. So this is a classic case of local pathology. Pelvic imaging will give you that there is multigenesis. Full points, 10 points to Dr. Devansh.
Okay, so we give 10 points to Dr. Devansh. Let's move on to next participant, Dr. Avinash and Dr.
I
Rakesh.
request all the attendees to kindly switch on your video because there may be a doubt that you may be Googling or something like that. So requesting everyone to kindly switch on your video.
And you need to be careful. Dr. Dinesh is watching you if you are Googling it.
Okay, whose question is this?
Dr. Rakesh, Dr. Avinash.
Avinash. Dr. Avinash, which of the
Yes, sir.
following are true? Options could be multiple. Which of the following are true regarding pubertal development in boys? Option 1 is lack of testicular enlargement by age 13 years qualifies for delayed puberty in boys. Option 2 is testicular enlargement before 9 years qualifies for precocious puberty in boys.
Yes, sir.
Lack of testicular enlargement by age 14 years qualifies for delayed puberty.
Yes, sir.
Commonest cause of delayed puberty in boys is androgen insensitivity.
Yes, sir.
Pubertal development in boys is earlier than girls. So which of the options are correct?
So 2, 3, 4. So 2,
Okay.
3, 4.
You think commonest cause of the delayed puberty in boys is androgen insensitivity. All right. So he has answered more than the required. So he has answered one extra option which is not correct. 4 is not correct actually. So how much we should give him score? I think 7.5.
Yeah, I think that's fair.
Yeah.
Okay, so Dr. Avinash gets 7.5, Dr. Rupesh. So the last question for this round will be to Dr. Anita, and Dr. Ravindra will be taking that question.
Which of the following is true about the pituitary gland? Pituitary gland is extradural in location. Pituitary gland is in contact with the CSF. Pituitary gland originates from oral ectoderm. Pituitary gland initiates the onset of puberty. Or pituitary gland starts secreting TS at birth. Dr. Anita, little bit difficult. Little difficult.
One is true.
Okay.
Third is true.
Okay.
That's it. 1 and 3.
That's good, great. Yes, it's a correct answer. And I'm happy to know that you answer it correctly and immediately. Full points to you.
So she gets, Dr. Anita gets 10 points, Dr. Rupesh. So by this, we come to the end of our 5th round and only one round to go. So Dr. Rupesh, please tell the...
Yes. After the 5th round, Dr. Devans is leading with 87.5 points. At number 2, Dr. Jaya with 40 points. At number 3, Dr. Avinash with 37.5 points. Dr. Ramsundar with 35 points. Dr. Anita with 27.5 points. At last, Dr. Neha with 12.5 points.
But
The first,
still
second,
anybody
third
can
now
win.
is Dr.
Still,
Devans.
Yes, Dr. Rakesh, can you say?
Dr.
Yeah,
Anurag was
Anurag.
saying. Dr. Anurag.
Because if you write 10 right, you will win. So everybody should go for it.
Dr. Neha is a first year postgraduate and all others are final year.
Never mind if they came into top 6, so definitely they have achieved. Sometimes the days is there, sometimes the days may not be there, but definitely you are the most intelligent people out of 600 delegates, and they all participated and you came out 6. So don't worry, definitely.
So now we come to the last round. That is again last rapid fire round. So Dr. Dinesh, you will be reading that round.
Yeah, I'll be reading the questions. I have already written the welcome round 6. So whenever they can write why.
Okay, we will start with the first question.
A boy with delayed puberty and anosmia, what could be the diagnosis?
Ram Sundar, Dr. Ram Sundar.
Kalman syndrome. Kalman syndrome, congenital.
10 points.
Yes.
Answer 10 points.
Okay.
Just a minute. Let me write welcome. Now you can move to the question number 2, Dr. Richard. Karyotype in Klinefelter syndrome. Avinash.
Sir, double XY.
That's the correct answer.
Double XY, double XY.
Okay, they said correct. Give him 10 marks. Dr. Rupesh?
Okay, sir. Thank you.
Marks to Dr. Devan. Dr. Devan.
Requesting Dr. Neha kindly select the panelist and attendee option. Your voice is coming privately to me, so that won't be visible to the panelist, and you will not get the opportunity to.
Put on the chat, not the
Dr.
Q&A.
Neha, you kindly correct your options. Okay.
Let her put once so that
Now,
she can.
Yeah,
Dr. Neha, just do practice.
Just
Neha, yeah. Now she has
I'm
done
writing
that.
welcome. Okay. Let's move, Dr. Richa.
Okay.
What is the most important test in hypoglycemia?
Dr. Ram Sundar.
We have to do CBG. I mean, like to confirm the capillary blood glucose, sir. Sir?
It is confirmed. It is confirmed. It is confirmed.
Basically, for the evaluation, how to go further.
We have to do insulin like growth factor levels.
Not the right answer.
-10.
Ketones is the most important test in hypoglycemia. So you get -10 for this. Dr. Ram?
Dr. Ram, IGF-1 is never being done in hypoglycemia. Insulin, yes, may be done. Insulin, ketone, free fatty acids, and glucagon challenge tests. These are the 4 tests are being done. IGF-1 is never being done in hypoglycemia.
Okay.
And to remind all of you, this is the last round, and this will be the final round. So you make sure that you will all win. So we can move to the next question, Dr. Richa. A 2-week-old boy with bilateral cryptorchidism, shock, hyponatremia, hyperkalemia, what will be the most likely karyotype?
Dr. Ram Sundar again.
Ram Sundar.
This is 46 XX.
That's the correct answer. That's the correct answer. +10. So Dr. Ram Sundar gets +10 points.
Okay, ma'am.
So I have written welcome. You can write a number. Move to the next.
Okay.
Karyotype in Turners. It's easy one.
देवांश का कंप्यूटर चला.
Sir, my
Devansh, please answer immediately.
Exo.
Don't Google.
But I answered previously.
Exo.
Those who are will be dealing, we won't get marks.
Dr. Richa, he's saying EXO.
Yeah, that's the correct answer. Devansh gets 10 points, Dr. Rupesh.
Okay, ma'am.
Yeah, let's move, Dr. Richa. Which thyroid axis hormone crosses placenta?
Dr. Ram Sundar.
T4.
That's not the right answer. It's TRH.
So minus 10, Dr. Rupesh.
Ji, sir.
Dr. Ram. You can move next. Presence of decay is most diagnosed type 1 diabetes in children. Type true or false? Ram
Sundar.
Dr. Ram Sundar, you don't write even before the question. Don't write why before the question. Wait for the question.
Yes.
If he has written before the question, I think we should give minus 10.
Oh, this is after the question.
10 is to decide.
False, sir.
Right, it's false. It's not must to diagnose. It's not must for the diagnosis of type 1 diabetes. So he gets plus 10 for this.
So we were moving to the 8th question. Dr. Richa, you please move. A tall boy with cardiac defect and the legs dislocation. What is the diagnosis? Dr. Jaya.
So,
I can't hear.
oh,
she is saying Marfan.
Marfan,
Yeah.
that's the correct answer. Okay, she gets 10 points. That's correct.
Okay, got it.
Connectivity
Yeah,
issue. But
yeah.
she's
With her slow connectivity, even her Marfan seems quite tall, isn't it?
So this is the moving to the second last question of this session. That is the question number 9. Dr. Richa, you can move. Most important hormone for regulation of calcium metabolism.
Dr. Ram Sundar.
Vitamin D.
That's wrong. Not the right
Minus
PTH is the most important for the regulation of
So PTH hormone is the most important hormone for calcium
Gets
metabolism.
minus 10 for this. It was Dr. Ram Sundar. I don't know. It was Dr. Ram Sundar.
Yeah, it was Dr. Ramchandra.
The last
The last question, Dr. Richa.
I would suggest in the question number 9, I would suggest that actually the question should have been a little more specified. For example, most important hormone for regulation of serum calcium or most important hormone for regulation of bone calcium. Then the answer would have been easier because it's not very easy to say. So if we are not giving plus 10, I think we should not deduct 10 in this case. Because vitamin D and PTH, they work hand in hand. Specifically, the question was, what the other panelists think?
Yeah, actually, I agree with this question, but I agree with you. Although we want to say that PTH is overriding because it converts 25. Even if you have vitamin D, no PTH, it won't be converted. But maybe we can take off the negative marking for this one.
Yeah.
But
Hey, Dr. Richa, if we have another question, we can make it 10. We will delete this question and we'll make it 10.
At the
it's
moment,
not hormone, but
or you.
We can make it 0. So whatever Dr. Anurag is saying, Dr. Bhanu is saying,
it is 0 effectively.
Automatically makes it
Minus
null.
marking. That's fine. Okay.
We won't be giving it minus. Dr. Rupesh, please note that.
How many points given to this question, sir?
कुछ नहीं.
0. ठीक है.
Not minus 10.
No.
Okay,
Don't deduct any marks for this question.
Okay, sir.
Let me write welcome and then we will move to. Yeah, Dr. Richa, we can move to the last question of this session. A 6-year-old girl with a cephaloid spot, breast stage 3, and vaginal bleed, low LH. What could be the cause?
Avinash Jha.
McKeown-Albright syndrome.
That's the correct answer.
Yes.
So here comes the end of our quiz. We'll stop sharing. Have the
Happy to know that still, I mean, more than approximately 70 people are sitting and watching this. I mean, I think hats off to
Besides
Dr.
the
Dinesh,
participants,
Dr.
people are,
Dinesh, his team, Dr. Richa, and I think all of us.
and to all participants of this quiz also, I
Yes,
think their friends
obviously.
are also among them, most likely, and they are bucking up.
Yeah.
They are cheering them.
देवेश के दोस्त बोल के आए होंगे जितना मिलेगा बाहर ले लेंगे उससे सब.
So, Dr. Rupesh, you have final score?
जी sir. Can I hear you?
Yes.
Yeah.
Sir, after
Go from last 6. Go in a reverse direction.
Okay, sir. At 6th position, Dr. Neha with 12.5 points. At 5th position, Dr. Anita with 27.5 points. At 4th place, Dr. Ram Sundar with 45 points. 3rd place is for Dr. Jaya with 50 points. 50.
Good. She will be getting prize, 3rd place?
Ji, sir.
Will be getting prize.
At 2nd place, Dr. Avinash, 57.5 points. At first, Dr. Devans with 97.5 points.
Very good.
Thank you, sir.
I must tell you, Dr. Avinash also won 2nd prize in the Palmocono also.
Oh my God. God. Man, that's really.
And even in the cuff module also, although there was no prize, but he was among the topper.
And this is despite the fact that he was awarded 0 in his initial 2 directly asked questions, which I asked. Yeah, good.
But we should congratulate to everyone because they have played very well. Dr. Neha was amazingly answered even in the first answer, and she has told all the 2 syndromes, and there were really difficult syndromes. So we must congratulate to all the participants. So can we take the first prize, second prize, third prize for a group photograph? Second is Dr. Who is first? Devansh is first, I guess so.
Devansh is first.
Yes.
I think we can have all the group photograph. We should not highlight. I request everyone to please switch on your video for a group photograph. Dr. Jaya, are you there? Dr. Ram?
Yeah, Dr. Jaya, I can
Please.
see you.
She's there, but there is some connectivity issue from
I
her
can
side.
see her screen also. I can see her on the. It's frozen. I am not sure, but I can.
Dr. Mansi, you are there. If you can please open your screen. Dr. Nagendar. Smile, I'm taking the. Rupesh.
Dr. Rupesh. Done.
Fine. So
We thank all the panelists who have stayed
so
long and patiently.
with this, we are coming to end of this 4-day long marathon conference on the pediatric endocrinology. And I congratulate all of you for active participations, especially Dr. Richa, who is really a backbone for this conference, and she has designed all the scientific sessions. She was very active for almost past 1.5 months. We were regularly in a contact, and she was really working day and night on this conference. I really thank to all the faculty also, especially Dr. Ravinder, who is always a dear friend, sir. Also, is a very active sportsman also, and a very knowledgeable endocrinologist, a very good member of IAP North Delhi. I thank you all the faculty, Dr. Bhanu, Dr. Rakesh, Dr. Anurag, and Dr. Mansi. And I thank you all the participants who participated in this quiz, and to the whole faculty and to all attendees. In the future also, we'll be conducting a similar kind of conferences. And we have two patrons. One is the general conference and the other is the subspecialty conference, which we have already done. First conference of this year, the specialty one was on pediatric imaging. That is the Imagicon, which we did in the Crown Plaza Hotel. And after that, the lockdown happened, and we carried on with the hematology conference, the Hematocon, and then Pulmocon, and now this is the fourth one. So thank you very much.
Thank you,
Dr.
Dr.
Shalini,
Dinesh, and thank you, everyone.
Thank you, sir.
Shalini, you want to say?
I just would like to express my sincere appreciation to all of you who helped us to make this event successful. Thank you so much, all the faculties, and I congratulate all the winners of today's quiz. Over to you, Dr. Richa, if you want to say something, please.
I have also all the thanks and gratitude to all my colleagues, Dr. Dinesh, Dr. Shalini, Dr. Nagendra, and so many, Dr. Ravinder, Dr. Shobna, and so many people of our North Delhi family who have assisted in everything. Then thankful to all the delegates who have been listening to us, have been interacting and making a program a success. Without them, the program doesn't exist. And most of all, a thank to all the faculty having been so interactive, replying to all the answers in the chat box and actively participating in the workshop. So I congratulate the winners of the quiz and all the best. Thank you once again and stay safe.
There were certain new additions for this conference, I must highlight. The workshop was the new addition, and it was very well, it was very useful also, because interacting face to face was a new experience. It was a new experience even for us. For the initial workshop, we had some glitches also, but later on we came out of it, and now I think we are expert in it. And the today's workshop was went very smoothly. And now I request the organizing chairperson, Dr. Rupesh Sharma, to give a vote of thanks and to close this conference.
Thank you, sir. I would like to thank all the faculties, all the chairpersons, all the delegates for making this endocon interactive and successful. I would like to say special thanks to Dr. Dinesh Mittal, President, North Delhi IIP, Dr. Shalini Goel, Secretary, North Delhi IIP, Dr. Richa Arora, Organizing Secretary, and whole North Delhi IIP team for their efforts and making this conference successful. Thank you, sir.
Okay.
Thank you very much, sir. I request the faculty to, if you want to add something, sir. Dr. Ravindra.
Yeah. I just want to
Bhanu.
say hats off to Dr. Richa, Dr. Dinesh, Shalini, Rupesh, and all the team of North Delhi IP. It's really a fabulous show, amazing show. And I hope Dr. Anurag, Rakesh, and Dr. Bhanu will agree. This conference endocon is like a midterm ISPE. I mean, we have all the variety of topics and speakers right from Delhi to Turkey or Kuwait. Dr. Richa was very instrumental to call each and everyone, right from Menon sir and all the international speakers, apart from the national one. I think hats off to them, and they need a standing ovation. Unfortunately, we can't do on this, digital platform. Otherwise, we would have done
Clap
that.
to Dr. Richa.
But I will say that Dr. Bhanu was always to help. I have called him around 100 times. Sir, ye nahi aa raha, ye nahi samajh aa raha. And he has always been helpful. And
But I would definitely say that I had a couple of apprehensions when I was, but I am really amazed to say the way it has been conducted. And I would suggest that why don't you publish? I mean, this is a new thing. This is the need of the hour now. It's worthwhile publishing your experience with conducting workshop, and there are certain journals which require such kind of information. It's going to be wonderful. The way you have conducted quiz, it's interesting.
Thank you, sir. Sir, I
Thank
will get
you.
Dr. Anurag must be here. I think he has left.
I think he is left.
Not here.
Rakesh has also left, I think.
No, I think everyone has left, Doctor.
Yeah, I think Dr. Rakesh must be here because on his busy
There is
Sunday.
a interesting comments from our participant, Dr. Anuradha Behel. She's saying that I am 57-year-old pediatrician and feels like doing fellowship in pediatric endocrinology after this conference. Is it possible? If yes, from where? So it's really a compliment to Dr.
Yes.
Richa, and I request Dr. Richa, Dr. Ravindra, if they can answer her query. If she can do fellowship.
Have been Dr. Anurag Bajpai, Dr. Bhanu can say something.
So first of all, Richa, this is a very good compliment to you that you have caught a fish in your net at least. So, and to Dr. Anuradha, that's good. It's very nice to know that you're interested. See, there are a number of institutes. Earlier, there were just handful, but now there are a good number of institutes which are offering fellowship programs in pediatric endocrinology. So in the government sector, SGPGI Lucknow was the first one. So 1 year course SGPGI Lucknow is offering. Along with that, Bharati Vidya Peeth, recently Apollo, Dr. IPS Kocher and Dr. Anurag in Kanpur, they have also started. And there's one course in Gangaram also. And still I'm sure that I must be missing a lot many. There is another short option of 3-month observership program. So you can go to the ISPE website and see that what are the criterias. And so if somebody is not able to give the entire 1 or 2 years, there's a provision that you can spend 3 months in one of the centers which qualify to be called as the teaching centers in the ISPE. And you can spend 3 months, and ISPE in fact arrange for some travel grant also for that. So the details are available on the ISPE website. You can go and check.
I request Dr. Bhanu to put the website link in the delegate group.
Sure.
So for the benefit of everyone. So thank you everyone. So now we are coming to the end of this meeting and this conference also. Thank you very much. We will be meeting again very soon. Thank you.